Hello, everyone. Welcome to the CTeL RPM Summit. We are so excited to have you here with us today. The summit runs from 12 to 3 p.m. Eastern Standard Time. For those of you that are new to CTeL, CTeL is a 501c3 nonprofit research institute that focuses on all the laws, policies, and regulations that impact the delivery of virtual care. We focus on 3 subject matters. First, telehealth, second, remote monitoring, and third, AI. Today is all about remote monitoring and remote therapeutics monitoring. So if you are in this category in digital health and you care a lot about it, you are in the right place. So let's get the day started with our first session. Help me welcome Tucker Williamson, Legislative Assistant from Representative Neil Dunn's office, Republican from Florida, and Josh Joff, Legislative Assistant from Representative Sheila McCormick's office, Democrat from Florida. This first session is titled Congressional Insights on Remote Monitoring Legislation. Tucker, I'll hand it off to you to begin.
Hey everyone, thank you for having me. It's a pleasure to join you. I am Tucker Williamson. I'm with Representative Neil Dunn's office, his legislative assistant. Remote patient monitoring is an issue that it's gotten a lot of attention from members lately, especially as some of the telehealth conversations have happened in the committee landscape. So I'm sure most of you saw the AMA's recent change with the 16-day reporting requirement. One big hurdle that I think will still have to be cleared is we've got to get CMS on board. CMS, their billing codes are frustrating, and they're frustrating for a number of reasons. But there are some legislative initiatives to clarify that billing code and to allow providers to bill in that 2 to 16-day window. One of those is HR 5394, the Expanding Remote Patient Monitoring Act. This bill would clarify that CMS can use or can bill in that 2 to 16-day window that currently leaves that gap there. As far as legislative outlook for the end of the year, there are, I believe, 20 legislative days left in the calendar, and they're going to go quickly. And I think there's going to be a major health package that we can expect, and what exactly that looks like is going to be a little bit unclear until after Tuesday. I think we'll start to get a lot more clarity after Tuesday. It is Washington, and Election Day decides a lot for us. So I think we'll have some more clarity as to what exactly is going to be included in that package at that time. But I do think it's a strong candidate, and then certainly some telehealth will be included in that as well.
Josh, why don't you introduce yourself now and talk a little bit about the priorities of RPM in your office?
Of course. Well, hi, everyone, and thank you for letting me speak here today. I'm Josh Jaffe. I am the legislative assistant for Congresswoman Sheila McCormick. So I think, first off, Tucker hit the nail on the head. A lot of what's going to be shaped for the next Congress is probably first going to be dealt with at the end of the year. So there's some competing telehealth packages. So we'll see what finally gets included in them. We're probably looking at a 1-year extension. But for my office and what we're hearing from other lawmakers, I'll give you guys, 4 key priorities that lawmakers, specifically my boss, are looking at, and that's general awareness, streamlined reimbursement system, which Tucker just talked about briefly, broadband, and health equity. For general awareness, I think RPM and telehealth technologies are still very new. And so people think of these tools as kind of abstract, futuristic concepts, when the reality is that the future is now, that these technologies are here now and can be used. So I think Congress is going to be working with the patients, the providers, and the federal agencies to kind of educate the public on the promise of RPM and telehealth, and that they can be used by anyone, and that they're safe technologies. Going back to the billing codes, the streamlined reimbursement system, the cost of running a medical practice is higher than it's ever been. And if we want to incentivize the use of RPM by patients and providers, then we need to ensure that providers are being paid for their time. And the current codes, they kind of have some arbitrary limits. The American Medical Association just approved a change that gets rid of the 16-day a cap, but we still need to do more so that providers are encouraged to use these services. The next one would be broadband. So, access to reliable, affordable broadband, is foundational to the success of RPM and telehealth. And I think it's often overlooked. RPM and telehealth has the most potential in communities that are most likely not to have not to have reliable broadband. So whether that's rural communities and medical deserts. And that kind of leads me into the last priority, which is health equity. Congress wants to ensure that these exciting new technologies are accessible to everyone, not just the wealthy and well-connected. And it also means that when we're looking at these technologies, that they are designed for everyone. If you'll recall, during the pandemic, there were a lot of stories where people with darker skin tones were getting inaccurate readings from pulsometers and being sent home, and then were subsequently experiencing complications. So we want to ensure that as we continue to use these new technologies, that we're working with the developers and the manufacturers to really ensure that they're capturing everyone, everyone's skin tone, and that they're accurate and can be used by everyone to ensure the best health outcomes.
Thanks, Josh. Let's just dive into some questions here that I know the community has. So we're expecting an end of year package. We believe that vehicle is going to be the Telehealth Modernization Act because that'll allow for the extension in terms of reimbursement opportunities under Medicare. When we're thinking about the larger package, how does RPM fit into the equation? What are we looking at in terms of reimbursement? Is there any dialogue on the Hill about RPM, or is more the focus just we have to focus on these extensions and give a very clean extension rather than add some new components into the bill?
Yeah, absolutely. I think as we discuss these things, the more you add to a package, the more complicated it gets. And with anything touching Medicare, Medicaid, we have to do it in a budget neutral way. CPO can often get in the way of that, but they are the referee on the field, and we have to play by their rules. With that said, I think that there is some room in the package. It just it all depends what happens, like I said, on Tuesday. I think if either party really wins a unified government, I think that the shift becomes the first 100 days of the next administration. So it's tough to say before Tuesday, but I do think there is some wiggle room in there. But costs are going to be a big concern with whatever that package is, just because of the nature of passing legislation that touches CMS. You just got to be budget neutral with it, and we got to play by CBO's rules.
100%. So much of it's going to come down to the election. But I think so much of it also is just going to come down to cost. The first question anyone asks when you introduce a bill is, how much is it going to cost? And the Congressional Budget Office, we know the cost saving impacts of remote patient monitoring. We know, we spend $4.5 trillion annually, 90% of which the CDC attributes to chronic conditions. And we know RPM is so good for chronic disease management. Mm-hmm. The question is, though, what is it going to cost? The CBO tends to score in a very limited 10-year window. They're looking at kind of expanding that to 30 years. So that's on the back burner, and that's another challenge we're going to face. But I think, cost, I also think there's a little bit of a turf war, right? So Ways and Means and ENC both pass their own telehealth packages. They're both very similar, but there's also some key differences. Some include priorities of other members. So there's going to have to be some sort of negotiations before a year-end package moves forward. I think with the government funding deadline coming up on December 20th, that could either complicate matters or, make things much more simple. The speaker has kind of said, there's not going to be a year-end omnibus, but, we have a government funding deadline. There is an election coming up. So I think all of these are definitely going to complicate matters, but it also presents an opportunity for, remote patient monitoring, small things here or there to be included in a final package.
Thank you, Josh. So I noticed that you're using the word telehealth a lot. And if you talk to anybody in the RPM community, RPM is very different than telehealth. But on the Hill, is there still room for more education for CTeL and to others to educate that, telehealth is point in time care and remote monitoring is either remote physiological or remote therapeutics monitoring that's monitoring a patient for a period of time. Up until 2 weeks ago, it was 16 plus days within a 30-day calendar period.
No, 100%. And there needs to be more education. I kind of use them interchangeably, which I shouldn't. I think there needs to be more. And I think when we look at it from a legislating perspective, we associate them. They're very closely related. And I think just looking at the telehealth extensions for the end of the year, I feel like that's going to impact so much what gets done on remote patient monitoring heading into the next Congress. I think once we kind of lay the base for telehealth, once we kind of set a clear a pathway forward, a clear extension, that's gonna kind of lead to like, hey, now we can kind of act on remote patient monitoring. Because I think that there are a little bit more there's a little bit more complexity, right, with managing remote patient monitoring. It's ongoing, it requires transmitting of data, it's more complex, it's longer. A telehealth visit's 30 minutes. When you're getting monitored, it's 24 hours a day, 7 days a week. So it's really important to distinguish that, and thank you for correcting me. I don't mean to
Oh, not
conflate
correcting
the
you at
two,
all.
but just important that I think when we're looking at it, we're kind of looking at laying the foundation first with telehealth and then jumping to remote patient monitoring, but it's definitely on everyone's radar.
Yeah, and I think you're right, Josh. Like on the Hill, the terms telehealth, remote monitoring, and to some extent AI are used kind of interchangeably. They're all deemed as telehealth. And I guess the question that I have for you, Tucker, is what does that mean as we enter into the 119th Congress in January? How do we work on legislation as it applies to remote patient monitoring?
Yeah, absolutely. One of the big notes I wrote it in all caps, was we need to educate members about what the tools actually are. I think, you have two staffers from two health-minded offices here today, but that's not everyone on the Hill. 435 members when we have a full chamber, and they're just not all going to be health-minded. I think when you can educate members and their staffs about what these tools actually are, that goes a long way in allowing us to craft legislation that fits more dynamically within the RPM landscape. I think as we turn to the 119th Congress, it's going to be important to get in early. They're the first 100 days of the next administration. I expect tax policy is going to dominate the conversation, but there is going to be some room for some good health policy to come along as well. So being early in the next Congress, I think, is going to be really essential to move something big. With that said, I think as we can bundle issues such as telehealth and AI and RPM, I think it makes it more digestible, especially to move it through committee processes. It allows members to think about the issues in a system and in a network of care that I think is a worthwhile exercise, especially when you want to have one bill's easier to move than three, right? So it certainly makes sense to bundle some of these issues, but all that said, it also is helpful to have individual pieces that members can throw their support behind and signal to leadership that these pieces are what we support, even if that means in the end they get bundled together to actually move through either chamber.
So I have a question for both of you now. I guess the pro of taking telehealth, remote monitoring, and AI and kind of putting them in one digestible bill is that you can get the community behind one bill and you're educating on one bill. But if we're still talking about the CBO, telehealth has to be scored differently, RPM has to be scored differently, and so does AI and however AI is integrated into digital health. So how does that actually impact the trajectory of a bill. It seems like it would almost be harder if we put together a bill that kind of had everything in it, because it would have a larger score by CBO, potentially.
Yeah, absolutely. I think that's where there's room for so whenever we do legislation like this, we like to use what we call pay-fors. And the pay-fors are they're meant to bring the cost of the bill down. So for example, with the telehealth bill that moved through Energy and Commerce earlier this year, we used pharmacy benefit manager pay-fors to move that bill through. And so I do understand that when you bundle them together, you make the CBO score harder to overcome. That said, you can look for one big pay for instead of having to combine multiple pay fors into 3 pieces of legislation. I think when you're looking for those pay fors, sometimes it's easier to identify one big one, and you know pay fors that are bipartisan and not going to kill a bill are they're hard to come by. And so whenever you can make that process simpler, I think it's worthwhile.
I agree. I think that when it comes to combining these, different types, RPM, telehealth, different types of bills, it also presents a unique opportunity to also, address something else that's going to save money. So for the Ways and Means and Energy and Commerce packages, they coupled it with pharmacy benefit manager reform, which has, been a hot button issue here up on the Hill, but a lot of people are eager to address it. So I think that going into the next Congress, if we do have one, big RPM, telehealth, artificial intelligence package, it gives us an opportunity to address another issue that maybe is costing a lot of money. So whether that's price transparency, um, just any other types of cost saving measures that are super pressing that have been a longstanding issue. So I think it presents an opportunity to kill 2 birds with 1 stone.
Now,
And I'll
go
say
ahead.
real quick, I do think AI presents a very interesting pathway to find some pay fors. I think AI is meant to make providers' life easier, and it is designed in many ways to promote efficiency in the system. And I think there's ways to craft AI legislation that actually could result in it scoring as a saver. And if that is ever the case, then I think attaching the two make even more sense.
Tucker, you read my mind. I'm so glad you brought up AI, because when we're talking about AI could be something as simple as a very sophisticated questionnaire, or it could be an algorithm that is used to remove white noise in RPM data. So, if you're monitoring a patient using a smart wearable and you have 30 days of data on that patient's heartbeat, you don't need all 30 days, 24 hours of that patient's heartbeat. You just need the outliers. And AI can be really good to remove some of that white noise and just take the important pieces of data and send them off to the nursing team, or have that escalated to the cardiologist. But I want to talk about AI as it applies to state policy, which is clearly outside of your realm because you're at the federal level. But there seems to be a problem where you have states that really haven't yet addressed AI as an appropriate way to engage or treat a patient at a state legislative level, or even at a medical or nurse licensure board level. So, but then if we ultimately create legislation that says, yeah, you could use AI and you'll get reimbursed for it, what is the message that we have to tell to our state policymakers? Because that kind of confuses things, especially for the clinician saying, well, I could be reimbursed under Medicare, or I could be reimbursed under Medicaid, but my state medical board or my state nursing board actually doesn't have any language on how to use AI, or they do, and it might be more restrictive than what federal law says.
I think this is a very important case of engaging the private stakeholders and the state and local officials on the ground, because Up here in Washington, it can be a little bit of a bubble, but you are all our eyes and ears on the ground. So I think that when we're addressing this problem, the fragmentation between the federal level and state level policy, we need to be super duper careful and we need to get this right. I know that there's been a lot of hype, but also a lot of caution that artificial intelligence is going to change the game, but it's also dangerous. It can lead to catastrophic consequences. And we agree. And that's why we need to make sure that if we're going to develop a solution, it needs to be very carefully thought out. So I think engaging with everyone across the stakeholder chain, whether that's patients, providers, state and local level officials, we need to craft a package to make sure we get it right on the first try, because we all see what happens when we try and rush into an issue. There's a bunch of unintended consequences. And then a lot of people are left kind of being like, well, I don't know what to do. Am I allowed to use AI? Am I not allowed to use AI? Am I going to get paid if I do this? Am I violating the law? Am I compliant with HIPAA? So there's a lot of different considerations. I think that the Senate working group, led by Chuck Schumer, Mike Rounds, they've done a great job. I think being really thoughtful, taking in feedback from all the different private stakeholders. They've had a bunch of closed meetings with academics, people at Google. So I think we need to be very deliberate and very careful. We don't need to rush. But it definitely needs to be on our radar. And I think lawmakers know this. And it's also about educating too our lawmakers, because AI is very complex.
Yeah, I couldn't agree more. My boss sits on the House AI task force. And we hear all the time about the great advances that AI is going to bring to the healthcare space, and we're really excited about them. I think in a lot of ways, it's here to stay. It's not going anywhere. We're not gonna legislate it away. It's gonna be around, and so I think as it becomes more ingrained in society, it'll come along, especially at the state level. One of the trickiest things that I think we're going to have to address at the federal level is twofold. How is the FDA going to treat it? And then how is CMS going to bill it? I think both of those issues are going to be things that we have to do really thoughtfully. Because in many ways, AI and CMS billing run counterintuitively. CMS likes to focus on provider time as kind of one of the benchmarks to how much a service is going to be reimbursed at. Well, with AI, the whole point is that we're saving physician time. And we still need to recognize that, even though physicians are going to be seeing a patient for less time, it's still a very valuable tool that they can use to treat a patient better. And we need to incentivize people to find creative and new ways to use the technology. And then at the FDA side, we need to make sure that our regulations on that, on the device side, are going to adequately keep up with changes and advances in artificial intelligence. I think it's already advancing faster than really anything we've ever seen. I think ChatGPT just released a new model that is heads and tails above the rest, and we were all blown away by the others. And so the speed at which it's going is pretty incredible. And it's going to be really, really important for Congress to get ahead of it, because if we don't, it's just gonna lap us, and it's much harder for us to catch up to it. The speed of government, it does not go at the speed of technology advances.
That is true. We have about 6 minutes left, and I want to open it up to questions. So if you have a question for our congressional panelists, please open up your mics and cameras and feel free to ask away. Do we have any questions here? It's probably because you guys did such a great job in giving a strong background to your presentation. All right, well, I have another question. CTeL created this. We talked to members of Congress, and we've been educating about telehealth and the differences between telehealth and RPM for years now. And then there was this question about, well, how is AI integrated into RPM? Because RPM is now actually being used a lot for the treatment of mental and behavioral health disorders like substance use disorder. And we have a CTeL member that is using AI to predict cravings for SUD patients. How does something like that get reimbursed? So is it to the benefit of, would congressionals like yourselves and your colleagues on the Hill, we created this AI collaborative that has experts from all the main academic centers like Cornell and Dartmouth, Harvard, Penn, UC Berkeley, and the list goes on. So all of the major Ivy Leagues and public Ivy Leagues are part of this. They come from medical, clinical, technology, and legal. Are these people someone that the Hill would like to hear from, that we've gathered to talk about how you integrate AI into digital health, all aspects of digital health?
Yeah, absolutely. I think we definitely would be well suited to hear from those stakeholders. I mean, this is a great example of something new that that you just told me about, and I feel like I hear a new one every day. Yeah, I mean, I think learning how to reimburse that is it's gonna be incredibly it's gonna be tricky. It's gonna be something that is gonna get us outside of how we normally think about CMS billing codes. And any ideas that we can get from, some of the top minds in healthcare is absolutely welcome.
I 100% agree. And I think that sometimes, CMS has been very slow to kind of adjust to the economic realities that a lot of, providers and patients face, especially when it comes with new technologies, medical devices. So it's really important that that when we have these amazing new capabilities, that we're talking with providers and patients on the ground and seeing how that they're responding and how their behaviors and practices actually translate into something that can be billed, whether that's through a code. I don't know. We're gonna have to talk to the experts, the academics, but there's always room to kind of expand how these things are paid for. And it's one of the biggest challenges that Congress has faced over the past, 20 so years, especially as medical costs have continued to rise.
Absolutely. It looks like we have a question here. This is from Vishnu. Vishnu, if you'd like to open up your mic and ask it, you're welcome to, or I could do it for you. Oh, go ahead.
Yeah, sure. I just wanted to ask, we saw the code changes from the AMA. Do we expect some reduction in the reimbursement amount for the codes, especially when you're monitoring less now, considering that the overall CMS cost containment is something that you're looking at?
I certainly think it's possible. CMS is gonna get creative in how they work the codes. It's hard to predict even for us. I mean, they in their fee schedules, they like to run the numbers around, and they do some really creative things. I think one of the unfortunate things that we see happen a good bit is that just the baseline reimbursement level goes down year over year. And that's something that Congress is going to have to, I think, step in to address, especially as we see a consolidation of providers into one network. I mean, it's really hard to keep a medical practice alive right now. I think, reimbursement reductions are certainly something that they might look to. It's just hard to say. I'd want to talk to CMS before I put words in their mouth, but I wouldn't expect it's off the table.
I 100% agree.
Thank
Oh,
you.
sorry.
No, go ahead, Vishnu. Sorry. Or Josh, go ahead.
Yeah, no, I just wanted to add, I think that Vishnu's question really highlights a huge debate that's being had on the Hill right now. I'm sure a lot of you tune into the congressional hearings, and when they have the telehealth experts come on, they talk about telehealth and remote patient monitoring and how they should be reimbursed. Some people think it should be less because, it's virtual, you're not in the office. It's being done at a patient's home. And then you're also doing that against the backdrop of continuous, Medicare physician fee schedule cuts. The conversion factor is going to be cut again this year by like 2%. So providers are struggling, and if we introduce these new technologies, it might let them see a bunch of new patients, but they might be getting reimbursed less for that. So we're also gonna have to carefully look at that, but that's been a long-standing debate, especially with the rising costs of running a medical practice.
Well, I wanted to tell you both, thank you for joining us on today's panel. This is the end of session 1. So thank you again very much. And I will take you up on your offer to say hello to you at the beginning of the 119th and introduce some of our AI Blue Ribbon Collaborative members and our RPM experts. But now we're going to move on to our second session of the day.
Thank you very much. It was great to join you.
Yes, of course.
Thank you.
And we're just going to give a minute for for our speakers to join us. All right. Second session is AI and machine learning and remote patient monitoring. We are lucky enough to have with us Dr. Ravi Parikh, who is a medical oncologist at Emory University, and Dr. Fei Wang, who is also part of our Blue Ribbon AI Collaborative. He's a professor of population health sciences and director of the Institute of AI for Digital Health at Weill Cornell Medicine. We thank you so very much for you joining us today. I'd like to hand it over to Dr. Ravi Parikh to introduce himself. Dr. Parikh?
I believe we're trying to get him on at the moment.
Oh, okay. Sorry, I thought I saw that he joined. Just give us 1 minute and Dr. Wang, are you on with us?
Yeah, I'm here.
Okay, there you go. Why don't you take it first while we wait for Dr. Parikh?
Yeah, of course. Hello, everybody. Nice to see everybody and appreciate this opportunity. So I'm currently a professor of health informatics in population health sciences at Weill Cornell, and have been working on AI for medicine in the past 15 years. My training is hardcore computer scientist, and I have been focusing on machine learning and AI for health applications. And thank you. Nice to see everyone.
Dr. Parikh.
Hi, everyone. I'm Ravi Parikh. I'm a medical oncologist and associate professor at Emory University, where I run a lab that broadly focuses on applications of artificial intelligence in clinical care, running prospective trials and validations of those tools that might help us in clinical decision making.
Mm-hmm. So I'm going to just ask a general question, and you guys can each take a stab at it. How are you seeing RPM being integrated into digital health right now, into the overall digital health landscape and ecosystem?
So I'm happy to start if that's okay. So, when I think about applications in my own clinic, I kind of think about, I would say, three-ish applications. One is around communication. So, communication with patients and communication of treatment plans and the like. So, one example of that might be a bidirectional chatbot to try to assess symptom burden during the course of a clinical trial or during the course of a particular therapy that might be a little bit difficult. So an example of something that we integrated when I in my previous institution at the University of Pennsylvania was a bidirectional automated algorithm-based text agent to try to support individuals who are on a complicated chemotherapy regimen for the treatment of neuroendocrine tumors that required multiple dosing changes during the course of a treatment, and dose escalations that were pre-planned and honestly very difficult to adhere to. Another way that I think is particularly useful is in just data collection outside the clinic for metrics that we think may matter for either research or for assessing symptom burden for a potential patient. So an example might be passive monitoring of something like activity levels for the purpose of performance status assessment during the course of therapy to give us a more granular assessment of performance status than what we commonly report in clinical trials, which is notably sort of biased and inaccurate much of the time. And then I think the third aspect that I've seen emerging is in the area of predictive analytics using longitudinal remote collected data, whether that be patient reported data, whether that be biometric, wearable, and the like, as part of broad patient and population level predictive models to help identify risk of adverse outcomes. So those are sort of three areas that I, have seen emerge in my practice.
Yeah, for me, I think I'm not a doctor, but I work with doctors day by day. So I see like for a lot of the research and also in practice, like from disease diagnosis, with these, RPM data, wearable data, we can do more precise diagnosis and screening. And to treatment, like Ravi, just to give the example, like to make the treatment more precise and also personalized, as well as like patient care. And I think that it was like one of the most natural application is monitor how the patient is recovering after the intervention or treatment. I just see like more and more seamless integration of leveraging more of these data captured not like in traditional clinical settings that can help both the providers and patients improve the patient care.
Yeah, absolutely. So this question is for Dr. Wang, and then Dr. Parikh, I'd like you to jump in right after. Dr. Wang, you are one of our founding members and a chair of the CTeL AI Collaborative, which is a group of industry academic experts that sit inside a CTeL advisory group that has no financial commitment to CTeL, and we don't pay you. It is completely as agnostic as you can possibly be, because we've noticed that there's a lot of AI groups right now that's kind of like pay for play, and we wanted to be very different than that. My question to you is, in the beginning, when I started in telehealth 16 years ago, it was just telehealth and it was just RPM. And in the last, AI has been taking place for a long time, but now we're starting to hear more about the integration of AI. How are we seeing the integration of AI into RPM? And what are kind of those pros and cons, like things that we have to adjust for?
Yes, I think first I'm thinking of technically, right? Like you said, we have been talking about integrating AI for a long time, but I think a lot of the times we really mean like in clinical setting or pharmaceutical setting. So what does it mean for RPM? So first, I would say AI play a natural role there, because RPM typically involves sensor data or continuous time data. So that means the volume is at a different scale, and the resolution is also at a different scale. Is also very different than like the traditional clinical data, but also the quality. A lot of the times there might be more noises in these remote monitoring data. So that means when we do the integration, we have to be more aware of like the pros and cons of the methodologies, like what can be really applied here, what cannot. It's not like ChatGPT can solve everything, right? And then, related to that, so now we are leveraging more data. Like in the past, when we talk about the privacy or security, it's really, you just protect the clinical data, don't let go out of the hospital. But now, like we have all those variables, and we are thinking about like RPM, maybe at patient home. There might be more ways to access patient data. So there will be more chances for unauthorized access to sensitive data. And more important, like nowadays, like these large models, research have shown that we can even do reverse engineering to recover the patient sensitive data even without knowing your raw data. So there are lots of challenges from model perspective as well. And then the next thing would be like from ethical and regulation perspective, nobody is completely clear about the capabilities and also the dangers and risks of the current AI and medicine landscape, and especially in RPM, as I said, it's even more complicated. So like rigorous evaluation and consortium like us, and also like these other, groups, are important to set up the standard and to make everybody understand the potentials and the risk.
Mhm. Dr. Parikh, you deal with a very medically sensitive patient population, and AI does well based on the data that you put inside the platform and the algorithm. Are there any times that you're concerned that the data that might be going into the AI algorithm to monitor the RPM data for patients that are very critically ill could potentially cause a risk or liability, not only to the patient, but maybe a legal risk and liability? Is there anything that you are working to safeguard against?
Certainly. Well, I think this answer is probably not RPM specific, but the way the current liability framework for clinicians is with any digital technology is that anything that may go wrong is largely on the hook of the clinician, because the clinician is viewed as in the loop and interpreting some of the outputs to lead to a clinical decision. I think the way this maybe applies for RPM is just in the sense that most of the output that we might get from, say, a continuous glucose monitor or some sort of wearable health tracker, or even a symptom-based reporting tool, a lot of the times when we get output as clinicians from those, it's framed as very raw output, or like interpreted in very high-level summary metrics that aren't necessarily tied to a clinical action. And so because our liability system is engineered such that we don't want to be making an error for a patient, the overwhelming tendency for physicians, either because of liability or because we just get so much information, is to ignore all of that data, because we don't know how to interpret it. And so I think this is a big potential as we do more rigorous validations of these AI technologies, is in the interpretation of some of these signals in ways that can be multi-institutionally validated, cleared by the FDA, and actually on the label for some of these RPM technologies, because then we would have more trust in how to use it. I think, one example for the CGM sort of devices is a time in range, which is a very crude sort of metric, but something that's understandable by physicians and can help us understand, okay, are there peaks and valleys and sort of triggers for a glucose to become out of range, so that we can actually point towards an action for a patient. Maybe they keep a food diary, and so they understand when they're getting out of range and things like that. And so then that leads to something we can actually do, and it's helpful for us. But I would argue that most of the RPMs out there are not structured such that they're actually helpful for clinicians, and that leads us to ignore them.
So alert fatigue is a big problem among clinicians.
Totally.
And there's just too much data. The other question is, and this has been, there was a great journal article published in JAMA by Dr. Koppel and Dr. Kreta, and it's called Hold Harmless Cause, the Implications for Patients and Clinicians Using AI. And the article goes on to talk about how it's in our legal structure in the United States, we've structured this in a way that the clinicians are held responsible, just like you said, Dr. Parikh, and not the inventor of the technology. So the vendor solution is not going to ultimately be held liable. It's going to be the clinician's going to be held liable. And so there has been some concern by clinicians saying, if there's just one more tool that I am given, and I expect that this information is supposed to make me a better doctor, but it could also put me in a position of liability if I just don't have the ability to take in all of these data points. what would make, so the question for both of you, Dr. Parikh as a clinician and Dr. Wang as a technologist, how would you encourage vendor service providers to better create endpoint solutions for RPM with the integration of AI?
I might just offer two things, and I'm interested to see what Dr. Wang has to say. But one is focusing less necessarily on the algorithm. The algorithm is important, but focus on the user interface of how you're going to present information to clinicians, and do multi-stakeholder testing, do rapid cycle user design, all these words that we put in our grants to sort of emphasize translation. But I think it's really helpful on my end, because there's so many better ways that the outputs of RPMs can be visualized that we're just not getting. The second, I think, is when there is demonstrated evidence, and there is evidence for things like arrhythmia monitoring, for example, that remote patient monitoring AI-based solutions may actually do better than end user clinicians. Push for automated, the FDA has approval pathways that are admittedly stringent, but that are intended for more autonomous AI-based agents. Especially in these situations where involving a clinician in the loop might actually lead to less timely and more inaccurate diagnosis of certain disease. Now, those examples are few and far between, but I think they're going to be coming as AI technology gets better. And so that is only to the benefit of the patient if, a malignant arrhythmia is automatically detected, directed to some sort of triage-based service, as opposed to relying on a clinician interpretation. So as the tech gets better, I envision that some of the translation barriers are going to diminish.
Yeah,
Dr.
for me, I think from a technology perspective, first, I completely with Ravi's comment on focusing more on the user interface, the interpretation, and also, the communications, really bidirectional communications between the algorithm results and the end user, the clinicians and the providers. So, nowadays, sometimes we focus too much when we talk about machine learning. We focus too much on the algorithm itself. Largely ignore like how to communicate the results and let people understand better. And number two is really the evaluations. I think Ravi already talked about multi-institutional, but I would add even beyond that. So nowadays, when we talk about validating or external evaluation of an algorithm, really mean like let's say with regard to an outcome, the prediction performance should be similar across different, let's say in order to alleviate bias, like across different race, ethnicity group, and also across different geographical area. But think about after your model is deployed, it's gonna be there for a long time. And the disease, let's say the COVID, right? It comes with different waves, and different waves, you're going to have different characteristics associated, and patients demonstrate different symptoms and signs. So nobody can guarantee your model can work well forever. Then what you're going to do? So are we going to also, we talk about RPM, but are we also going to monitor the performance of the model over time? Like when we observe a decrease, so how much the decrease is going to trigger a retrain or fine tune? And how are you going to guarantee like after you update your model, it's not overfit, which means that you tune your model at one hospital, actually it's getting worse in another hospital, which is possible. So all these things, long-term monitoring and the evaluation of algorithm performance hasn't been done too much yet. Because I think now pretty much the focus is still on validation across different locations and sites, but longitudinally over time prospective way is also important. So yeah.
So we have a good deal of hospitals and health systems. We have some venture capitalists and private equity that are on the phone with on this meeting with us today. And I think one of the questions that they're constantly trying to understand is all AI created equal? Is all RPM created equal? Because I think for the investment side, those that are coming from the private equity or the venture capital space, or those that work on Wall Street, they are thinking about how do we invest in companies? How do we invest in companies that are compliant? How do we invest in companies that are actually putting together like a good platform or a good AI? And the hospitals and health systems that are on this call and some of the substance use treatment centers, they have the same questions. They're asking like, we have limited resources as a hospital or health system. How do we know what to select? Are there some checklist items that you could offer when they're going through this process of selecting a vendor or an AI service provider or both?
Yeah, well, definitely, I don't think all AI is not created equal. Everything that's developed in Dr. Wang's lab and Dr. My lab is definitely better than no, I'm just kidding. But like there is yeah, I would argue that there are certain internal checklists. So I help participate in AI governance at my current institution. And when we're getting a material, there are certain things like FDA clearance, for example, and that are that we can use as sort of internal list, but FDA clearance doesn't apply to everything, and oftentimes the standards for FDA clearance aren't necessarily super great all the time anyway. So a lot of times we're relying on internal checklists, and I would say for us, there is a few validity-based checklists, like has this been validated on actual patient care? Is this something where there is peer-reviewed or white paper-based evidence that can actually be checked? Is there another deployment that's gone on that we can use as a reference for us, in terms of how the model can work? So those are like, certain things. I would argue that, the more common but less well understood, internal checklist is just related to like feasibility of deployment. So oftentimes, for example, a digital pathology tool requires you to have digital pathology, or to have your pathology images digitized. A chatbot-based tool requires you to have some sort of mobile app interface to collect patient-facing information upon which your algorithm will work. And so I would argue a lot of the time, many of the health systems, including sometimes ours, that are being approached just don't have the technical specifications necessary for these algorithms to actually work. And so even if we're super excited and there's great data behind it, we can't do it. And so I would love to see some sort of nutrition labeled like checklist attached to these tools before we even waste the time for a meeting to know whether we can actually do the thing that they want us to do.
What a neat idea. Dr. Wang, what are your thoughts?
Yeah, I think Ravi, raised a very good point about attaching label to these models and tools. And actually, like one of the recent it's not necessarily a product, but output from, CHAI, you also mentioned like the Coalition of Health Artificial Intelligence, is they create something called the model card. So they kind of like characterize the model into different aspects, like performance, like parameters, data types, whatever, biases, and they put it as a card. And then you can fill in the different characteristics. It's kind of like you attach a label to the model. I mean, that's just one example. I'm not saying that's a golden standard, but kind of like trying to initialize this kind of efforts. And also another point I want to echo Ravi's point about like when we talk about these checklists, right? So there are a lot of these like CHAI type of efforts across the nation. Across US, you see all kinds of like guidelines or those like they expand the traditional clinical trial type of checklist and incorporate AI and see what you're gonna check. But none of these can be perfectly applied everywhere. Like Ravi has, let's say Emory AI working group to develop those checklists for like, that works well for Emory. here, I mean, in my institution, Weill Cornell and Columbia associated with, NYP, New York Presbyterian, and we also have an AI working group, and we also actually, Ravi, the example check items you gave are also in our checklist, but they are also, meeting after meeting, and also with all these inputs from different people, and also in the process of reviewing those AI projects, that checklists get longer and longer and more comprehensive. Some of them are just, really customized to the unique needs from NYP. So we need some broader, general guidelines, but also there will be some customizations and the personalizations.
I think that brings us to a really neat deliverable that the AI collaborative could probably work on is, and we would invite you, Dr. Parikh, to participate if you're interested. There's no cost to you, just a bit of some of your time, but we would love to probably put together a draft checklist of what is considered important. And in addition to that, we probably also want to add in compliance factors too. So there are issues dealing with a model could be technologically appropriate, but it might not necessarily be medically compliant and could put a practitioner at risk. And so we almost need to create multiple silo checklists: science, clinical, legal. Yeah, that's a really neat idea. And I'd invite your thoughts or feedback on a potential deliverable like that for the community. Do you think that would be valuable?
Absolutely. Yeah. I mean, I think, there is these emerging sort of AI governance committees that are coming up in hospitals and health systems. And oftentimes anything AI related gets routed to them, including a potential AI solution within an RPM framework. And so, doing some informal surveys with those governance committees to get a sense of what they routinely vet, and then coming up with, some sort of checklist that they could use, or potentially down the road, internal certification standard to sort of put a stamp of approval on certain technologies would be hugely valuable for me, as an often end user in some of these things.
I think it's a fantastic idea. Because I think the questions that we field most of the time are, wait, are these the same? They're basically the same. They're telling us they're the same, or, and they're using all this fancy terminology, and we'll say, well, no platform could technically be, no platform is created HIPAA compliant, but you have to meet HIPAA standards. And so there's some of this like fancy language that somebody that is being sold a product is kind of confused about. And I think the other problem too is that, when you're looking at the health system perspective or the hospital perspective, they're often saying, we don't know what we don't know, and we want another source of information outside of the person that's trying to sell us the product. And so that's why we've created that Blue Ribbon Collaborative, is really kind of an agnostic resource for these types of tools. We have about 2 minutes left, and I just want to open it up to the floor to see if we have any questions for our two experts. Vishnu, go ahead.
Thank you. Yeah, thank you both so much for your perspectives. My question is more about how are you thinking about AI applications in patient education? I'm thinking about this from the context that, hey, now they have more RPM data. Really from the Cures Act, they have other data as well now, right? Lab data and everything electronically. And then the shortage of healthcare professionals is also exacerbating the fact that they may not get the right education on what their data means. And how do you see AI playing a role here? And what are the considerations, regulatory perspectives? So just, yeah, overall.
Ravi, you want to?
Yeah, I think that so one area that I've been really I think would be fantastic would be sort of autonomous interpretation of low risk patient level charts or notes or documents that are shared through patient portal. I can't tell you, even though oftentimes sensitive documents are delayed by a few days to allow physicians to call patients, a lot of times my patients get access to documents before I have the chance to kind of call them about a potential interpretation of an image, of a note, of a scan. And so I think there's a lot of potential for just general education as to what a test, that they might see on a portal is reporting on and what it means. And of course, caveating that interpretation where there's uncertainty and where appropriate. But I think there is a good amount of potential for patient education around that area. I'm not sure, Dr. Wang, if you have other ideas, but that's at least something that comes to mind so that patients aren't left in the wind.
Right, right. No, I'm just about to say, because I'm not a doctor, but I am a patient. So whenever I got some, let's say echo or some, lab test showing abnormal, so I always ask ChatGPT, what does that mean? And then I go, let's say, got a call from my doctor. Sometimes I ask question, my doctor said, no, don't believe that, and what this is what and what. So I think certainly they educate me to understand more about some of the things, but at the same time, remember, so all these generative AI models can hallucinate. So don't just blindly trust them, still follow what your doctor's advice, but at least, like Ravi said, it can put you into some context so you have some awareness on, the potential problems and conditions you have, yeah.
I want to be able to address this question from a student. Maria poses a question in the chat. She said, I am a senior year bachelor student from Pakistan. Maria, I actually did my graduate work in Pakistan on telehealth, so I'd love to connect with you after this. Working on STEMI, STEMI detection using 12 lead ECG. I'm also making a Flutter application and will integrate this model to app to support clinicians. What features would you prioritize to enhance clinician engagement and support real-time decision-making? That'll be our last question, but if our team of experts want to give her some advice.
I don't know what is this STEMI. Is it, I assume it is a cardiac condition.
Yeah, yes, but I think this is probably a great conversation for a cardiologist who works in AI, and I think Dr. Wang and I probably know a good number of people who focus in this area, so we can probably connect offline.
Yep.
One thing I learned during my oncology fellowship is to never give cardiology advice. I'm always wrong about anything there. So I'm gonna just stop talking.
Saji Sakaria, one of our CTeL members, actually did confirm it's a heart attack. But Maria, if you could drop in your email, I will connect you to our two colleagues here on this panel, and they'll put you in touch with a cardiologist specializing in AI. All right, well, thank you so very much. We really appreciate your time today. Thank you again, Dr. Parikh. Thank you again, Dr. Wang. And we encourage all of you to, if interested in our AI collaborative, especially the integration of AI and RPM, to join it. We dropped in the link earlier in the chat, and looks like Maria actually just dropped in her email as well. So I hope that you're able to get in touch with the right people. Next up, we have our third session of the day. It is data-driven clinical outcomes and financial benefits. We have with us Dr. David Bates, Medical Director of Clinical and Quality Analysis at Mass General Brigham, and Dr. CTeL Parikh, Senior Medical Lead at Google. And I see Dr. Parikh on, looking for Dr. Bates. Are you here with us too, sir?
I'm here.
Oh, there you are. Okay, I see you. Dr. Parikh, Dr. Bates, why don't you tell us a little bit about yourselves, and then we'll dive into some questions.
Sure, I'm David Bates. I'm for 25 years as the chief of the Division of General Internal Medicine. I stepped down from that role recently, and now I'm co-direct a Center for AI across MGB.
Great, thanks. Hi guys, I'm CTeL Parikh. I'm a cardiologist. I've been at Google for about 10 years, worked on search, Google Fit, and now support enterprise efforts that connect all of Google's tools with our large enterprise clients. I see patients 1 day a week at the VA here in DC. And then prior to this, I spent a decade at Johns Hopkins.
Thank you. We are very delighted to have two noted names in the RPM and digital health community here with us to ask and answer all of our questions. So let's kind of dive right into it. A lot of the questions that we get from hospitals and health systems is, I want to do RPM. It makes a lot of sense, especially for our substance use disorder patient populations. But the only problem is I can't make the financial argument that RPM is going to save us money because we can't specifically point to RPM as the cost saver. Do you want to kind of talk and address a little bit about that specific piece regarding the financials of RPM?
Sure. I mean, David, do you want to start and I could jump in, or vice versa?
Why don't you go ahead?
Yeah, sure. I mean, this is a question, as we think about, so I've helped support sort of implementing technology solutions, whether it's RPM or cloud, et cetera. And it's a common question in terms of the financial return on investment. In the short answer is it's a little complicated. So it depends on how the incentives are structured. In this, I'm talking sort of broadly, this is not just the US, but I've supported programs in the UK, Singapore, India, et cetera. So you just have to really follow the incentives. So for example, if you're trying to do one post-hospitalization, then many of us know there's 30-day readmission penalties, and many RPM programs have been known to reduce those. So like there's a mechanism there. In other sort of areas, hospitals are now taking more risk. And so they either have some amount of like risk-bearing contracts or have ACOs or other ways of bearing risk. And so if you can reduce the overall cost of care, which RPM has been known to do, that's another way of integrating it into the sort of mix. Another approach is sort of more indirect, which is RPM programs can improve quality metrics. And these are metrics that hospitals care about. There are leaderboards that get reported out publicly. Some of them are tied to reimbursements, et cetera. And so that's another angle for it. And then finally, RPM can be a funnel for sort of more complex cases that then can lead to more revenue. So the example I give is, psychiatry typically, or infectious disease, or even a heart failure cardiologist like myself. Many of these are actually loss-making as a clinical enterprise. So when I see a bunch of patients as a heart failure cardiologist, most of what I do is in-person visits. I don't read echoes. I don't put catheters in people's hearts or stents in or things like that, which are far more lucrative. But they keep me around because I send people for all those procedures. So the downstream revenue for the health system is massive. And so if you can thread the needle of where the financial benefit is in any one of these ways, I think you have a way in. I think there's a less direct, it's not like you have this incredibly lucrative technology that you say, hey, if you start, deploying this, you'll get a ton of revenue from direct reimbursement. It's more indirect.
And I agree with all that. And I would say the more accountable care you have in your population, the more likely you are to be able to make a justification. And it's worked especially well for CHF populations and COPD, patients with pretty severe COPD. So it's a lot of the benefit is in patients with relatively severe chronic illnesses.
So if a hospital is not necessarily willing to play the long game with RPM, are there more immediate incentives that they could look at in terms of financial cost benefit if they're trying to decide if they want to integrate RPM into one of their service verticals?
Yeah, sure. So I'll take the example of substance use disorder and describe a program that we did with Fitbit. So this is a company called Preda, where they had a bunch of social workers that were supporting substance use disorder patients. And what they were trying to do is they have social workers that do outreach. And one of the components that they put in place is they gave these patients a bunch of Fitbit devices, and they had programmed it such that if you have resting tachycardia, a simple notification pops up. Do you want to speak to somebody? Now, resting tachycardia, which is fast heart rate when you're not doing anything, could be someone like me right now, giving a talk, my heart rate's a little elevated. If I get the notification, I'm like, no, I'm fine. Don't need to worry about it. On the other hand, if a substance use disorder patient is withdrawing and actively withdrawing, they may have tachycardia at rest. And at that point, they may want to speak to somebody. They might click yes. And the reason this becomes useful from a financial perspective is instead of like having these social workers call like some people on Monday and some people on Tuesday, they can target these people for the most effectiveness, right? Like, so you're increasing their efficiency and efficacy through the technology. So that's another, like, the efficiency play is another angle to approach. And David, if you want to add more, I'll pass it over to you.
No, I would just say that was a great example. And I would just say that there are probably lots of things like that, and most institutions just haven't worked them out.
So would your advice be, if you were an institution, to not look at all of your medical service areas and say, okay, we're going to apply RPM to those, but to look at a few that might be more cost increasing, like SUD, and might offer a better, more immediate return on investment if that hospital actually has to show financial benefit within a certain period of time?
Let's step back a little, honestly. Sorry, David, you look like you were about to say something. Do you want to go? I would step up a little bit, right? Like, so when you're thinking about where to deploy a brand new program, I think financial is only one part of the consideration. So I typically, as I think about like all the pieces that have to come together in order for this to work, in addition to the financial component, you need to have, in essence, some clinical champions. So like a clinical use case that makes sense, or failure, substance use disorder, whatever the case is. But then a bunch of champions that will actually carry the work forward and on the ground, whether it's clinicians, but also like ideally office managers, et cetera, who will actually do the deployment and make sure that the stuff actually works. And then you have to sort of then go through like legal, regulatory, privacy, all those kinds of things to make sure that information is kept secure. I mean, that's something we think a lot about at Google, but like all of the like compliance hurdles, in essence, both at the health system level, technology level, et cetera, that you have to go through, as well as the financial piece. So if you think about financial, clinical, regulatory, privacy, all of those things, where you see all of that lining up, the political will, that's where your greatest likelihood of success is. The last thing is, when you're doing a brand new implementation, I think you want to find a partner within your institution that's willing to fail and willing to iterate. The first implementation is never going to go perfectly. And so you want to have somebody, a group of people who's willing to, sort of roll up their sleeves and figure it out when things don't go exactly as planned.
Yeah, I guess I would say that eventually we're going to want to do this for a whole bunch of chronic conditions. That other ones that we've worked on include asthma, migraine, MS. Those are all things that get better and worse. But you've got to, as was just emphasized, CTeL just emphasized, you've got to have people on the back end who are interested in making it work, and you want to start there, because if you don't have some successes to begin with, it's going to be tough to maintain.
I think we have a question here from Michelle Hager from Blue Cirrus. Michelle, do you want me to ask the question, or would you like to go on and open your mic?
I can ask it. Thank you. So I'm just curious, given your experience with remote monitoring, I'm seeing a rise in some considerations around medication adherence as a remote monitoring solution. And even though that may have quality benefit for the patient to say, yes, I took the medication or didn't take the medication, I'm wondering if you see that as meeting the requirement from a financial and billing perspective for a physiological data point.
The short answer is probably not. I'm not an expert on this, but one of my good friends is Robert Jaron, and we spend a lot of time talking about these kinds of things. And so I'm channeling him right now. So if you think of the remote monitoring codes, technically, there's two sets of them. So there's remote patient monitoring, or RPM, and there's RTM, which is remote therapeutic monitoring. The RPM codes are much more specific on physiologic monitoring. So honestly, like things like Fitbit metrics, for example, don't count. And most of them are consumer grade. There's a few Fitbit metrics that are FDA cleared, but for purpose of this discussion. And so they wouldn't count for remote physiologic monitoring, remote patient monitoring for those physiologic codes. Remote therapeutic monitoring, on the other hand, is meant to be a little bit more broad. So you prescribe some some treatment, and you're now monitoring remotely. And that could also include like patient-reported outcomes, patient-reported measures, things like of that nature. For example, if you're doing physical therapy, compliance with exercises can be included in this remote therapeutic monitoring. I know somebody who runs a startup really focused on that, and he helped drive some of those codes through. And so you could, in some cases, put that in. The other thing I would say is that medication adherence is an interesting thing in that oftentimes there's a talk that I went to where one of these designers said, like, you know, medication adherence, people just think you need reminders, but it's sort of like if you had a reminder every week to call your mother, you may or may not do that because it's more complicated than that. It's a relationship, right? Like, and so patients have these complicated relationships with their medicines, with their caregivers and the care teams. What we have seen in our work, though, is that if you have the right sort of care team and like really what comes across is that they care about you, the remote monitoring is an extension of that care team. And so when people feel like they're being monitored, they're being watched and supported by people who care about them, not only do they do the like physical activity recommendations or things like that, but they take their medicines, they stop smoking. And so it becomes an extension of the care team and in essence, the care that's provided. So I think dedicated remote, like patient medication adherence as a remote therapeutic monitoring might be a possibility, sort of go check with a lawyer. But then many remote monitoring programs will, as a side effect, as a side benefit, have an increase in medication adherence. And then David, if you want to add to this.
Yeah, we focused more on adverse effects as opposed to are you taking the medication? And lots of patients have some adverse effects and are really interested in talking to someone. And you know, that is another use case which, you know, which I think can be pretty helpful.
Yes, thank you. And I'm going to clarify around the RTM. At this point, I believe that is limited to the physical therapy and the respiratory diagnostics. So it would be limited in those two areas. Thank you for that answer. I appreciate it.
Of course.
Let's talk a little bit about the issue of data collection and informed consent. There's elevated concern that data might be being misused or might be or could potentially be hacked. How do you go through a process of appropriately obtaining informed consent from your patients to let them know that they are going to be giving access to some vital data, and this information is going to be shared across the health system?
I mean, ours is done pretty efficiently because time is just precious and it can't take very long. I mean, there's some principles around doing this. You want to make sure you communicate clearly. You have to make it clear to the patient that participation is voluntary. You want to have some documentation and formally written consent is required. But it can be electronic. You want to tell them that you're going to respect their privacy and confidentiality, that they have a right to withdraw, that you want to make sure that they're competent. You got to deal with any state regulations because things vary a lot by state, and then there's specific restrictions for certain populations, like underage kids.
Yeah, I'm happy to build on that. So I think, you know, consent is something that not just sort of for remote monitoring, but as an organization, Google thinks a lot about. And we have to get consent from billions of our users for very sensitive data, not just health data, right? Like, so if you're sharing your location on maps, or if you're sharing your photos or your private emails on Gmail and photos and so on. And so what we try to do is, like, some of the principles are, like, we make it very clear what data is being collected, what it's being used for, and who is having access to it. And the other thing we have is a platform. So whether it's through Android, Health Connect, and a whole bunch of other services, we have platforms where this data is potentially shared across different apps. And so we try and make it as clear as possible. Here are all the apps that have access to your data. You can toggle it on and off and sort of try and make it clear. I think the thing about consent is, it's not that people don't want to share data. I think what people want is they want to get value out of it. And so the reason you're comfortable sharing your location data is because you get directions from where to go, or, you know, things like that. And so if you can demonstrate the reason for collecting it and then provide them value, it's worth getting the consent. Excuse me.
It does seem to be more valuable, and people people understand the ROI almost immediately.
Exactly. So you have to articulate why you're doing it and what their benefit is. And sometimes it's like it's a research study, so you articulate it's a benefit to society, you'll advance science, et cetera. But if you're upfront and clear about that, it makes the whole process like a lot more transparent and easier.
So I'm gonna go a little off topic here because this is a question that I was asked this morning by a vendor service provider. They said, we use these awesome active listening devices that are just completely integrated into our home. And we also have wearables that often can communicate with these active listening devices. And they are able to ascertain information about us that could potentially help us in an emergency situation. So the question that I received is, if you are constantly hearing, is if the active listening device or the wearable is gathering data that is projecting that this person might be a diabetic, it's inappropriate way the law stands right now to essentially have direct-to-consumer advertising to that patient about diabetes medication or to alert them to go see their doctor. But it seems that these active listening devices and these tools and these RPM tools and this integration could be a lifesaver for somebody that might not be taking a proactive approach to their health. Have you thought about this at Google? And if so, I'd like to learn more about that.
It's a complicated question. I'm not sure I fully get it because on the one hand, it sounds like they're saying, listen to conversations, figure out if somebody's diabetic and send them ads.
Mm-hmm.
We're not building any such product. I can assure you that. I don't know everything that goes on in the company, but that just sounds like something that would raise all sorts of red flags. I think the broader context of the question is, how can our devices be more helpful for people with health issues? And I think that's something I spend a lot of time thinking about. And it goes beyond, an active listening device or a wearable. So some of the things, I'll start from a couple of things we've already launched and then sort of paint the bigger picture. But, for example, this year we launched on the Pixel Watch loss of pulselessness. So if the watch stops detecting a pulse, it will, first alarm you, hey, are you okay? And if not, then call 911. And so being able to detect that somebody may potentially be in cardiac arrest and get help is potentially life-saving. And so that's the sort of, those are the kinds of tools that we're working on, which actually enable the detection of, essentially potentially life-threatening conditions. I've personally formulated a research study that's currently underway on how can we detect undiagnosed diabetes, hypertension, those kinds of things using consumer-grade signals. Who knows if that'll actually turn out to be anything, but like with AI and all these modalities that we have, there's a possibility that, we'll be able to detect those kinds of things. Some stuff that we've published that I can't speak about is we show that with external pictures of the eye, you get an area under the curve of about 80% where somebody's diabetic versus not. With retinal images, you can actually understand the grading of retinopathy. You can understand cardiovascular disease better than an ophthalmologist or retina specialist can, right? And this has been published in Nature and JAMA and so on. And so there's a whole bunch of research and products around sort of using our technologies for health. And I think there's a ton more opportunity there. In terms of sort of what I spend a lot of time thinking about is how does this all come together, right? So you can do remote monitoring with a Fitbit device, for example, but then you can use our Health Connect platform to connect in a Bluetooth, blood pressure, and other devices, things like that. You can then use cloud to display this information, use AI to make it easier for clinicians to understand and interpret signals so you can predict the next event. You can then send patients education through YouTube because video makes it a lot easier to understand than reading text. You get past health literacy barriers. There's a bunch of equity components there and all those kinds of things. So I'm not sure if this addresses the question, but these are the kinds of things we think about and focus on rather than just trying to serve up ads to somebody who's diabetic.
And at the other end, I would say, I work a lot on sort of signal to noise issues, and many things, get picked up and they're just not correct. Like my watch has thought that I had a hard fall on numerous occasions. And I never have. Now, if I do have a hard fall, I'll be glad to use it to dial 911, but it's probably gone off, 100 times or so. And in none of those occasions have I had a hard fall. And in the hospital, we give doctors warnings all the time. The positive predictive values of many of those warnings is really, really low. When we get into people's homes, we don't want to be telling them all the time that their house is falling down, or that they're going to have something serious go on. So it's really important to work on the performance characteristics of the suggestions like that.
Mhm. Thank you for that. We have about 5 minutes left of this session, so I'd like to open it up to questions and answers. Looks like we have a question here. Joe, I believe this is Joe McMenamin. If you'd like to ask the question out loud, or I could do it for you.
Sure, Krista, thank you very much, Joe McMenamin. And thanks to both speakers for really engaging discussion. My question is whether either of you or both of you can recommend literature that's especially effective or well done in your view, demonstrating the cost effectiveness and or the ROI of I've mistyped it, RPM, or even better, a good way to do a search, an effective search to find such literature.
Yeah, I mean, CTeL may know this better than me. I think some of the best work comes from CHF, but some of the work on CHF and remote monitoring in the VA was really good.
Mm-hmm.
This is a particular, I'll get on my soapbox for two minutes and then get off. This is like something that I feel strongly about. So in my opinion, the biggest challenge with remote patient monitoring literature is that a signal is only as good as the intervention that is tied to it. So if you have, in heart failure monitoring, a beautiful system that collects all the data, shows it to the clinician, and the response is, I'll see you next week, that system is not going to show you any impact. And what you need is something in place. The nurse will call you, you'll get an appointment next day, you'll get IV diuretics or whatever you need, etc. And if you don't have that intervention component, and this is true for designing the program too, by the way, not just the literature, if you don't have the intervention arm tied together with the detection arm, then your program is not going to be that successful. The systematic reviews of remote patient monitoring data lump all the studies together. And so then they kind of look like they're mediocre at best. And if you pull out the ones that are actually truly good intervention arms, it's actually pretty powerful. But no one, to my understanding, no one's split because then you have to have an intimate understanding of the intervention to know that this is what qualifies as good and bad. And, these are the ones we get. Then you get you'll get shot for like, oh, you just cherry picked a bunch of the ones that, seem to be good, et cetera. But in practice, that's one of the challenges. And so the literature makes it look less effective than it truly is.
Yeah,
and I'll get off that.
Yeah, we did a study in the inpatient setting, but we used a non-contact monitor that it measures the patient's pulse, their respiratory rate, and tells you how much they're moving. And the company that built this set it up so that when the nurse gets notified that something doesn't look so good, half the time the patient really has something substantial going on. That was very highly cost effective, and it was a cost saving within about a year. Some of these technologies I believe are definitely going to make a difference. It's a matter of dealing with all the performance characteristics and not lumping everything together as CTeL suggested.
May I follow up to that?
Yes, please.
Thank you for those answers. I guess this is for Dr. Parak, although I'd be interested in anybody's thoughts. You've made the claim that the literature does not do the job it should of demonstrating effectiveness. I'm happy to hear that, but how do we know that?
Yeah, I mean, so I think if you look at the studies that are well done, you can actually see this. I'll give you an example. So in cardiology, in heart failure, there's a loop monitor that you can implant not a loop monitor. It's a pressure sensor that you can implant. It's called a cardiomagnetic. But there's a device you can implant in the pulmonary artery that measures sensors. So it's the most invasive form of remote monitoring you can imagine.
Mhm.
And they showed pretty outstanding results. And there's a lot of sort of question about whether that was because you get such beautiful signal from the device, or because what they did was they actually, the device manufacturer had a nurse practitioner attached to it. And they had like all the intervention pieces really well established. I'll give you, so that's one anecdote. The second is, prior to Google, I spent a couple of years at Hopkins running a heart failure program. And we showed, as a result of the program I started, we reduced our readmission rates from one of the worst in the country that was around 30% down to 14% in 18 months, in part because of a remote monitoring program. But honestly, it was because we had this very effective intervention arm where we could bring in patients for IV diuresis. And I've published on that two separate papers, one describing the program overall and one describing the diuresis clinic. I'll also paste in the chat a systematic review that's that does talk about a range of conditions. And overall, it does say the economic sort of benefits are supportive of RPM. I think there's also a couple of other caveats there. So one is they point out, which is fair, is that like publication bias, because you don't necessarily publish negative studies as much as you do positive studies. So that maybe counteracts a little bit the like lack of effective intervention pieces. I think that the key is literature is a starting point and to understand sort of what's been done and what others have tried to structure and so on. When you're implementing it in your own system, I think you have to just take into account the realities on the ground. And again, like your data is going to be the best data, and so start small and then build up from there.
Thank you.
Unfortunately, that will have to be our last question. It looks like, okay, thank you. If you have any other questions, feel free to email them to us and we'll pass them along to our speakers. So thank you very much, CTeL. Thank you, Dr. Bates. We really appreciate your time today and we look forward to working with you again in the future. All right, next up, we have session 4, and session 4 is titled RPM and Reimbursement, Navigating the Financial Landscape. We're lucky to have with us Zachary Hosteller. He is the Director of CPT Editorial and Regulatory Affairs. He is with the American Medical Association. And we are going to talk about all things RPM reimbursement today. And probably highlight a little bit about that 16-day rule, 16-day of gathering data rule too. So Zachary, would you like to introduce yourself?
Hey there. Yeah, as was previously mentioned, my name is Zach Hostetler. I'm actually the Vice President of Coding and Payment at the AMA. You may have interacted with my predecessor, Jay Allman, previously, and there's others at the AMA. I think I heard the name Jaron in the previous session, and so he's on the Digital Medicine Payment Advisory Group who advises the AMA. So there's a lot of different aspects that the AMA has specifically around digital health. There's also we're in the I run the CPT educational area. There's also the physician satisfaction area that has produced a couple studies that I might talk about here related to payer reimbursement, as well as some just additional projects on getting physicians to adopt digital technologies as well. So a lot going on at the AMA related to digital health and specifically RPM and RTM.
Thank you, Zach. So let's get right into it. I think the question on everyone's mind right now is the removal of the 16-day requirement. Can you talk to us more about that? And is this final or do we need CMS's approval? What does this mean practically for those that are trying to submit for reimbursement?
Yeah, so let me walk through. I think this is going to be what just be helpful for me to, at the forefront, talk about what the editorial panel just did, and then I can walk through some of the implications for that. And so at the last editorial panel meeting, hopefully some of you or the majority of you were interested parties, and that's just a process that we allow people individual companies or stakeholders who want to follow specific issues that are in front of the CPT editorial panel, allow them to review the application and submit comments and sort of otherwise participate without being a direct applicant. So at the last September meeting, so about 30 days ago, actually about 5 or 6 weeks ago, the panel accepted revisions to the RPM and RTM codes. And so let me just walk through some of those because those will be important. However, I will say that the panel, we always work a few, roughly a year or so ahead of time, ahead of publication, and that's because Medicare has to work through their valuation process, and so these codes would be active, or the revisions within these codes would be active for 2026. And so we'll have all of next year under the current system. And then that's because next summer, Medicare will be reviewing recommendations for valuation, as well as then having a 90-day comment period. So there's really no way around that delay. And so the specifics of the proposal that the panel just approved, and this has been a result of the last over a year now, so almost 2 years of back and forth. And one of the challenges that was had there was just because the industry had grown so quickly after the creation of the codes, there just wasn't always consensus about the best way to handle revisions to the code set. So some people thought that, well, maybe that it was a good idea to sort of collapse RPM and RTM together, or at least have one treatment management code set. And I think there was just some concern around doing too much to an industry that was so nascent, as well as that had positive coverage, at least on the Medicare side. It's a bit mixed on the commercial side. And so there was several different iterations that came through in order to try to land on something that both modernized the code set for current, based on the sort of the feedback that we've been receiving, as well as not making too many disruptions because Medicare's coverage has been so important, as well as other coverage policies across the U.S. So all that leads up to a number of different things happen. One is that the device supply codes for remote RPM and RTM there was a new code added for each. On the RPM side, there's just one, but as was previously mentioned, on the RTM side, you have actually 3 related to MSK and respiratory and the CBT as well. But those were reduced then so the 16 days and greater was kept, but there is a new code for each of those for 2 to 15 days. And the literature behind that to necessitate the need for that was actually greatly enhanced from the pandemic. So we saw application, or peer-reviewed literature articles coming in that showed patient improvement, clinical efficacy for less than 16 days. And I think that's across a number of different service lines, but especially for those patients who were being monitored for COVID, but for less than 16 days. So again, this is an area in which the existing 16-day or greater codes were not removed. There was just a new code added to provide between 2 to 15 days. So there's never 1 day, but it's at least 2. And then there was also a change on the treatment management side, and that was to add a new code to describe the the remote physiologic monitoring treatment management services. Those were created to align. Well, so a new code was created to report the first 10 minutes. So previously it had just been the first 20 minutes. And so now you have a code for the first 10 minutes, and then for the first 20 minutes was the existing code, and then each additional 20 minutes, which was the add-on code following that. So that was, again, a little bit of there was sort of a little bit of give and take there as well, to try to keep the first 20 minutes a separate code than the first 10 minutes. And again, that was just to try to head off any concerns that coverage plans may have as to whether if they didn't want to cover the 10 minutes, then would they still cover the 20 minutes, those types of things. So again, some of this is just trying to determine what is, sort of how payers may respond to some of this stuff. But ultimately, that isn't a concern of CPT, and they did try their best to just accurately report or describe what the service actually is. So hopefully that's a helpful sort of intro into what recently happened. Again, there's just a lot more work to be done, and we won't sort of know what Medicare's coverage decision or thoughts on this won't be until July of next year when the proposed rule for 26 comes out. But in the meantime, these have been approved by the panel.
So this won't be in effect until 2026, assuming CMS actually goes through the rulemaking process and approves it.
Well, so I mean, I would phrase it slightly different in that it's the Medicare will go through the rulemaking process. It's just it's unknown what they will determine. A topic of conversation may have already been today, but could certainly be during this session, the CMS OIG report on remote monitoring that was released in September. There's certainly a lot of eyes on this sector, and so I don't know that I have sort of been led to believe they're sort of thinking about this any differently. But anytime you see sort of the vast expansion of services, the utilization increasing greatly over the last 4 or 5 years, and again, largely due to the pandemic, but and the removal of restrictions through congressional action, there's just going to be greater scrutiny on some of these things, and so it sort of remains to be seen how Medicare may see the sort of the further expansion of some of these services.
Thank you. A question that I received from a member that focuses entirely in the substance use disorder space is that they cannot bill RPM and RTM at the same time, but for their patient population, you could be using RPM technology to monitor if that patient is at risk for an overdose and monitoring their vitals, and also at the same time administering them a therapeutic to see if that therapeutic is working. Has there been any conversation about amending how you could bill for RPM and RTM? And if
I think that's a good question, because my understanding is that that's not a CPT rule, but a payer coverage rule. I'm unaware of, and I could be wrong, but I'm unaware of, I was just trying to look at what I had in front of me here. I'm unaware of any discrepancies or any CPT rules specifically that wouldn't allow those codes. Because I agree, you could have a patient with one patient with actually sort of 2 separate clinical indications that you need constant monitoring for, but then they may be coming out of they may need MSK sort of monitoring or sort of treatment for PT on either something different. And so to me that shouldn't be that isn't a CPT rule that you can't build those together. But if that's a payer rule, then those are gonna, I think that's one of the challenges here, right? And the AMA put out a report, and I can actually provide it here. I can just maybe put it in the chat about the different coverage policies of commercial payers across the U.S. on digital technologies, RPM specifically, but across the several different categories. And it just shows sort of the variance that there are so many different coverage policies across the U.S. and even just and it's even just hard to find out who covers what and when and where and how. And so that just speaks to the fragmented nature of a lot of the US healthcare system and how frustrating it can be. So I'm going to put that report in the chat because I think it's a value add to our conversation. But it's also almost 19 pages. So it takes a little bit to get invested or, to fully digest. But I do think it's a good conversation starter, especially as you start to think about the landscape for a lot of these things.
Thank you, Zach. We'll look forward to downloading that and sharing it with our RPM audience.
Yeah, it's on our public website. Yep.
Thank you so much. I also have with us Carol Yarborough. She is the chair of our reimbursement working group. Carol, do you have any questions that you might want to ask of Zach?
Yeah, good morning, Zach. I'd come on camera, but I'm just a mess. So you guys all look great, and thank you so much. I guess my question would be then for the, the big announcement came out earlier this week about the approval of the new codes for RPM. In your guesstimation, would you think then that all of the RPM and RTM codes then would get a lower valuation by the RUC? I know that's not your bailiwick, but I'm thinking perhaps reimbursement or work RVU value is going to go down. Plus, it would be great to have any hints about the practice expense redefinitions for those initial two codes for both code sets, because that's been a big thing of confusion for folks too. Thank you.
Yeah, I think that's really important, a really important conversation to have, and a lot of it speaks to, again, how is the CMS or the Medicare program set up? And so there is a threshold for practice expense in the supply side at $500, and so as the current RPM codes were passed, there was $1,000 piece of equipment related to heart failure monitoring. It was essentially like an iPad connected with a peripheral. And so it was about $1,000. And so that met the threshold, right? And so it allowed for, the 40 or 50 bucks that is reimbursed for the device side. Now, treatment management is totally different. We can get into the differences and just make sure that people understand um, the um, the differences there. But of course, you have the training and education code. That is a practice expense only code, but it is a nurse, it's sort of non-physician time. So it's not supply or equipment time, but it is clinical staff time to educate and set up the patient with the device. Then there is the device itself, and that the only expense associated with that is the practice expense supply costs, as Carol, what you were sort of alluding to or bringing up. And so that is where you currently have the RPM device code for 16 days of monitoring for $1,000, which met that $500 threshold. And so herein lies the challenge. And this isn't a sort of a RUC issue. This is more of a cost threshold with the way in which the Medicare program is set up. So when you have now that the Medicare data has come in over the last couple of years, and it shows that by far the primary ICD-10 code for the RPM codes is hypertension. I don't know. I just don't know. But is the most common, is the typical device being used for that $500? I suspect that a lot of it's blood pressure monitoring cuffs and things like that, which may not reach that threshold. And so the question is like, what's going to happen with those? And I don't know, right? So I think it's been clear that Medicare has they have I think gladly crosswalked many things to these RPM codes. And so you could imagine a scenario where while the 16-day code is staying, and perhaps there was, some misbilling in which you were monitoring, or, you would move those hypertension patients to less than 16 days or so, and that the typical equipment would stay at that higher level for the existing codes. And then Medicare may say, okay, well, we still want to crosswalk everything to this code because there really hasn't been any payment for RTM as well. Everything's been crosswalked, right? And so Medicare, I haven't heard of any change, not that I would necessarily, but have heard any change from their perspective that they don't like this crosswalk approach. And so I would be on the lookout for how CMS is going to think about potentially crosswalking some of these things. And so then that was why, though, the panel ultimately created the distinction between 2 and 15 and 16 days or more, because it's likely that, there may not be much of a disruption. I mean, again, I really can't say, but it's possible that there may not be much of a disruption for the existing codes, and then there may be more of a challenge on the cost side for the lower codes, just because of the thresholds that Medicare have set up. However, having options allows Medicare to potentially continue their crosswalking approach to provide some reimbursement in this area. So I think that's what's been tough to really get our head around is so much of what Medicare is doing to pay for these, especially on the device side, has been crosswalking to this existing code. I don't
So
think Medicare has
would lo-
a,
I would
yeah,
love to see, I would love to see these treated just as DME, but
yeah.
I mean, it's low value DME and probably then that would cause more fraud or whatever. But there's already DME set up and then just use those two code or the one code as a DME code and be done with it. But you know, it's okay.
And
Yes.
so, I mean, I've heard Medicare have those, CMS officials have those conversations around that. And I don't know that they believe that they meet the definition of DME. If there were, I think, a concerted effort to try to help them potentially understand a pathway to get some of this stuff on DME, then they may be open to it. I honestly don't have any insight there. But I think it remains an ongoing challenge.
Zach, we're constantly getting questions from hospitals and health systems that say, we want to do RPM, we just can't get reimbursed for it. What is your message to those hospitals and health systems that are struggling with reimbursement?
Yeah, and so some of that deals with with outside of my expertise, in terms of some of how sort of physicians think about this adoption, and then specifically the health plans. I think there's, um, and so I don't know that I don't know that there is a right answer, but here are some thoughts. I think there's always a sort of some risk aversion, especially on the larger plans, that implementing a new code set, if there's some ambiguity around the use of the codes, and there's audits concerns. And so it's always hard to sort of get sort of a new service line up and running, especially if there's concerns around implementing that, or especially if you sort of see this OIG report and say, hey, is Medicare going to continue to cover some of these things into the future if they have all these concerns? Where I see physicians having the most success is really homing in on the technologies that really work. Now, there's obviously a lot of discussion going around that's in some ways being led by the Peterson Health Technology Institute. I'm sure many of the people on this call have seen those reports, and they've I think in some circles they may be quite controversial, but they look at the clinical efficacy of very specific um, um, uh, services around digital diabetes management, MSK solutions, and digital hypertension. And so, and they also look at the cost benefit sort of ROI on providing those services if they're adding additional costs into the system. And so, regardless of how you feel about those reports, or if you feel like they're accurate or not, it does sort of get into this conversation a lot of people are having as to, like, yes, we can monitor more. Yes, there are CPT codes. We can bill them. We can get reimbursement for them. But are they really truly helping patients? And so being able to home in on those service lines that really are providing benefit, or where you could see a really, like, the health systems themselves could really see that benefit with the patient sort of mix that they have, you're more likely to have sort of success in being able to show the clinical efficacy of those treatments. And then again, the codes are pretty well established at this point. So, if the challenge is sort of getting the health systems billing unit to sort of understand the importance, I mean, I think that there's sort of plenty of evidence, or plenty of documented usage of those. So it's probably less of the issue that they can't get paid because there aren't CPT codes. It's more about, is there hesitancy to adopt sort of this new line of care or whatever, because there may be audit concerns or whatnot. But there are many different, and you'll see on that plan the report that I submitted, that there are quite a few commercial coverage policies out there as well. And so perhaps really not trying to sort of boil the ocean with any monitoring of sort of any condition, any physiologic condition, trying to see if it can't work for one specific area and then expand from there.
Looks like we have a question from Priya Anand. from Kiva Health. Priya, would you like to ask your question? Okay. I think maybe Priya, are you there?
Sorry, I'm having.
Is there anyone else from Kiva that would like to ask the question?
Hello, if you can hear me, my name is Jyotsna. I'm also from Kiva Health. Is it
Yeah.
okay to ask a question? I think I put this
Yeah.
little in the chat. I put in an AMA link that talked about removal of 16-day reporting. And I was just checking to see if this is true because it came through an article through Fierce Healthcare.
Yeah, so I'm aware of some of their ongoing reporting. I think that well, so I guess I could just speak to the facts. So the 16 days of reporting, it was just sort of it never really meant anything. There was never like studies that showed that if you did 16 days of reporting, you were going to get better outcomes. It wasn't like this change from 15 to 16. It was really just a CPT rule that says, hey, you should be billing this throughout the 30 days or a calendar month. And then we have this rule that, I mean, it's sort of convoluted, but if we have this rule, it's like the half rule plus one. And so rather than 15 days, you can build up to 16 to 30 days for this code. But it was really just an administrative rule, nothing that really meant anything. And so we became aware of that, we're sort of aware of that issue. And so but the 16 days and plus still remains in the existing code. And again, what's important about that is that we just don't know how important that is to coverage decisions because that's all we've ever had. And so you have that system, but then, so that didn't go away. What you now have is an additional option to report monitoring between 2 and 15 days. Now, again, those RVUs are not set and the practice expense hasn't been figured out. But it's inaccurate to say that 16-day monitoring rule no longer applies. It's just there's now an additional code.
I see. Okay, that is extremely helpful. So thank you. My other question was going to be around, commercial payers. So when my care team usually calls up commercial payers asking about reimbursement, we often notice that they are confused about where to position remote monitoring codes. They are so used to getting calls that talk about classifying an urgent care visit, a visit that happened in the office, and a visit that happens at the hospital. But as soon as you talk about RPM, they usually don't know where to place it. And B, they end up classifying it sometimes as DME. Is there sort of more education around this for commercial payers that could potentially help companies who are billing these codes?
Yeah, that's interesting. And so it's actually related to a project that we're working on now, which is to provide some use cases and case studies for specific coding. It talks about place of service and some more of those issues, because maybe in some respects that's what's tripping people up. Although you typically bill the place of service as where the service was provided, and on the treatment management side, it's where the physician was in reviewing the data, and then the device side is where sort of be handed off. But and so we may have some that work is just getting started, but there may be some additional case studies that we're able to provide on the AMA website that might be helpful, because it sort of walks through sort of a patient scenario and then what codes you would use and sort of any additional modifiers and things like that. And so that may be, those aren't done yet, but it may be something I could report back. It would be on our website, but could report back or provide to some of the folks related to CTeL as to when that's ready, because it could be a helpful tool to help payers understand.
Yes, thank you. I really appreciate that, because this is often the challenge when you call up the commercial payers and you're trying to ask them if this is, this particular service is covered or not, which is our typical practice of calling and making sure the patient is covered before we get them on the program. But what I would like to suggest is having some sort of, how we get those cards from the insurance that clearly say you have to pay $10 copay if it's urgent care. If it's ER, then you pay $100. I really hope we have a time point where we have RPM listed there and it clearly says your copay is $10 or $20. And it would make it so clear because of the fact that RPM is done virtually, but the reports, when they are produced, are read by the doctor in the office. There is usually that confusion of what happened in the office and then what happened at the home.
Yeah. Yeah, and I don't know all the specifics around that, but I do think some of the work that we're starting to do could be really helpful around specifics, coding sort of use cases and stuff. So hopefully what we were able to produce here, I think by the end of the year, might be helpful.
Yes, thank you. Thank you. I really appreciate it.
Yeah.
Thank you, Priya. Thank you. Keep that help. Thank you, Zach. This is the end of our session, and we so much appreciate your insights today. This is incredibly helpful. And if you have, and it looks like we have one other question from Sarah Sasong that was in the chat for you, Zach. So you might want to answer that offline and connect with Sarah. Next up, we have our next panel. This is our 5th panel for the day. It is ensuring informed consent and remote patient monitoring. Our speaker is Adam Solander. He is a partner at King & Spalding. Adam is just running a few minutes late, and we're just going to pause here for him. So if anyone needs a restroom break, you can come back in about 5 minutes. To my team, Adam is having difficulty logging in. If someone could give him a call. Welcome back, everyone. We have Adam Solander with us. He is part of the CTeL legal resource team, and he is a partner at King & Spalding. And he is one of the known experts in privacy and security as it applies to digital health. Adam, I'm going to hand it over to you to introduce yourself.
Hi, great. It's wonderful to meet everyone. My name's Adam Solander. I am a partner in the data privacy and security practice over at King & Spalding. I focus pretty heavily on all things, data privacy and security. I do a lot of FTC work, a lot of work just around really managing data in new delivery processes. So very excited to talk to you guys today about some informed consent issues.
Yes, absolutely. So Adam, as we are thinking about remote patient monitoring and informed consent, what advice would you give to a vendor service provider that needs to get all their ducks in a row? And conversely, what type of advice would you give a hospital or health system that's interviewing a vendor service provider that's about to be selected to give RPM services to that entity?
Mhm. You know, I think there is some misunderstanding about whether or not informed consent is needed. And, you know, the term informed consent is throwing a lot of people off. My read of the law and my read of, you know, all the various state laws, I think everybody on this call realizes that informed consent switches state by state. But I think there's absolutely a requirement to obtain an informed consent. And, you know, while the use cases and, you know, the different modalities that you're talking about, hospital versus being a vendor, you know, that may change. I think, you know, the core building blocks need to be in place no matter what for any valid informed consent. So we'll get into that, and then, you know, I'll talk about a little bit of the different focuses if you're somebody vetting a remote patient monitoring solution or whether you are the remote patient monitoring solution. But there has to be, you know, at least some sort of explanation of what the remote patient monitoring is. And you'll hear the term over and over again, clear and conspicuous. So one of the things that clear and conspicuous means is that really anyone from, you know, reading, you know, the paragraph or reading or hearing it read to them, you know, by a physician or however the informed consent is grabbed, it means it has to be understood to an unsophisticated person. And that has become a big issue lately with the Federal Trade Commission, is not understanding what people are consenting to, especially in terms of their data. You know, at its core, you know, there's a couple of elements that I'll always put in there. You know, you have to have that explanation of the service, why you're doing it, that it's a plan, it's part of the plan of treatment, and you really want the individual to understand what they're agreeing to and what their obligations are. You really need to explain the cost sharing. There has to be a discussion there in an easy understood way of the expected benefits as well as the possible risks. I always include sort of more of a one-on-one informed consent where the individual signs off on things that I think are most important there. You know, obviously, you know, they have to consent to the services being performed, the monitoring, if there's going to be any observation, if there's any third parties that's going to be shared with, all depends on the remote patient monitoring service. But I believe that has to be in there. The big one, and really where hospitals will differ, especially in their diligence from companies, is really that HIPAA attestation and that explanation of data rights. And that is something where, you know, we do see a little bit of a disconnect between certain remote patient monitoring services and the physician practices or hospitals that they're serving. It really goes to that secondary use of the data. And, you know, a lot of the remote patient monitoring, when we're working over on the hospital side, the hospitals, you know, they're subject to HIPAA. Their ability to use and disclose that data is pretty well constrained by the uses and disclosures allowed in HIPAA. A lot of times the remote patient monitoring or just other app developers in whole are looking for broader, you know, patient rights and use cases for that data, which really falls within a gray area that can, you know, lead to problems from the contracting, as well as potential legal issues down the road from either OCR or the FTC. I always make sure that the individual understands the risk of failure, like tech failure. I think, you know, we really want to make sure that they have the ability to give that consent. I always have the medical emergency contingency, like, you know, don't rely on this device or emergency care. And I also have an attestation that, you know, the results cannot be guaranteed. I think those are sort of the core elements as we looked across all the different state laws. Those are the things that matter most to me. I also would include some liability transfer issues if you are a patient monitoring company, to make sure that, you know, we're not guaranteeing these results that you know, while there's certainly benefits from monitoring and, you know, proactively being able to treat issues associated with monitoring, you know, we want to make sure that both the patient as well as the physician understands that these results aren't guaranteed. I think, you know, the big difference for me and really the battleground here is the data. You know, remote patient monitoring is producing very rich data sets. It's, you know, a hot button topic for analytics firms. It's important that companies understand the difference between the HIPAA rights and, you know, uses and disclosures that are prescribed by HIPAA versus more of an individual consent based standard, which is in all the state laws as well as the FTC. And really understanding where those different laws apply to you will govern what you can do with the data from both an internal analytics perspective as well as an external, study, that type of stuff. All of that depends on how you're able to navigate, that individual signing up for your service versus going through the hospital, all those sort of different issues. Did I answer your question, Krista?
Absolutely. I have a follow-up question, if that's okay.
Yeah.
We saw recently that North Carolina just included language that requires informed consent for AI usage. And we talked about earlier in the day that, you have AI can mean lots of things, and sometimes it could sit by itself, but oftentimes it's the perfect partner for RPM because it's used to really get rid of a lot of that white noise and just collect the really important information, be able to transfer it onto that care team of either nurses or a more elevated care team like specialists. How do you navigate informed consent for RPM versus AI?
Well, you need informed consent for everything. I mean, in today's day, with really the FTC and with every state passing, data privacy and security laws, I guess I'll focus on that aspect for right now. Anytime you're collecting any kind of information from an individual, you're going to have consent. When we're in the RPM world, most of the time that falls within HIPAA, right? So we get the informed consent, some variation on what you would do from a normal treatment perspective, the elements we kind of talked about, then we're allowed to use and disclose that data however we want. Anytime you get any data, it doesn't even have to be health data. Anytime you're going to get into individually identifiable data or people interacting with the system that's going to collect data or generate insights, all of that now and under the law really needs some sort of informed consent. That individual has to understand how those automated systems are operating, what their data is going to be used for. If you look at the Biden executive order on AI and you look at, the AI white paper put out by the White House Office of Science and Technology Policies about 1.5 years ago, really consent and making sure you're clear and conspicuous on individuals interacting with AI systems. I think that's consistent with what you're seeing from North Carolina. It's also an area where people are going to get in a lot of trouble. We're seeing an increased focus from the FTC on data brokers, other collectors of information. Lead generation is very much, under attack by these different regulators. So without that informed consent, essentially the data becomes valueless. So unless you can show that you have that right to use that data how you're using it, it becomes valuable. It becomes valueless. Just as an anecdote, we were up talking to the White House when they were getting ready to put out, the white paper and the one thing that they kept reiterating was, we had the immortal life of Henrietta Lacks, where her tissue samples were used over and over and over without her consent. We believe now that's happening like hundreds of millions of times a day. So it's sort of a problem, that problem that horse may have left the barn, but they're going to try to get it back in. And they're starting to think about privacy and, monitoring of people really in a civil right type of way. So North Carolina seems consistent with the federal law, and anytime you're collecting data or performing any kind of service for an individual, they really have to agree to it. And you have to be very clear on how you're going to use and disclose all that data.
So we talked about, the key elements to having informed consent and kind of like your checklist for RPM informed consent. How do you get the patient to fully understand that they are consenting to RPM technologies or RPM/AI technologies? Is there anything that a vendor service provider or a health system should focus in on?
Well, I mean, clearly the gold standard is to document a conversation and document those notes into a medical record that follows the patient. Obviously, that's not possible all the time. I think a lot of it really comes down to that drafting. And, if you go and you look at what the definition of clear and conspicuous is, it really can't hide the ball. Like there really needs to be a easily understood pathway to understanding what they're consenting to. So any sort of tricky language, anything that wouldn't be readily apparent to a non-English speaker, those things really have to be vetted by the company. You have to go over it. You have to identify those areas. I think offering translations of it is also very helpful for, English as a second language individuals. But it really comes down to drafting. It has to be clear, simple, and, really has to document, what the risk, benefits, data uses, all those checklist items really mean, and get the individual to agree to them. If possible, document it.
Mhm. So you bring up another good question. What role does digital literacy play in informed consent? RPM is typically used for patient populations that are chronically ill and usually 55 plus, even though we're kind of seeing that change now because we're using RPM for all different types of medical service areas. Is there a role, or do you have to account for digital literacy when you are crafting these informed consent clauses?
Oh, 100%. I mean, and those are the types of issues that do crop up is, yeah, the informed consent was, an 8-point font as the individual scrolled through the application, and, it was written in a way that they couldn't understand. You're seeing a lot of that, like, and not to sort of change topics here, but you're seeing a lot of that with what the FTC and some of the states are doing around what they're calling dark patterns, which are, design elements that could be interpreted as tricking a user into agreeing to things that they wouldn't normally agree to. So the test case for that's really out right now with Amazon. We'll see what ends up happening with the FTC, but certainly digital literacy, accessibility of both the content as well as understanding. One thing that always concerns me when we get into a consent situation and, instead of explaining the privacy policy or explaining, the research that's going to be done, it's linking to another policy and linking to another policy. Those sort of design interfaces that are supposed to, improve user experience are the very things that can undermine that idea of clear and conspicuous. So yes, I mean, there's going to be, the ordering physician is another place where in those contracts, that's a way that you can make sure that, the ordering physician has had, the conversations about the risks and benefits, that the individual understands that it's part of their treatment path. That's, if you can get that, that's sort of the gold standard, and then documenting that in the medical record. But digital literacy, yes, it matters. And we have to account for that in drafting.
So Adam, let's talk about compliance. You and I both work a lot with the investment community, and they're known for, move fast, break things kind of mentality. And we often see maybe a culture of, this is not necessarily important. How do we incentivize an emerging growth company that is in RPM or bridging RPM, telehealth, and AI together to really focus on these compliance issues? Is there a competitiveness to being compliant?
Oh, 100%. I mean, first, just from the investment perspective, I mean, these are sort of table stakes items that need to be out there. So getting through that investment process, the compliance people, the funds, they're all looking at, these types of low-hanging fruit issues right now, because they're becoming so obvious to both regulators with all the passage, especially the data privacy and security laws. But the plaintiffs' bar has picked up on this. I mean, we've seen, huge numbers of, data use cases. We're seeing tons of, anti-renewal law cases where people are signing up for, services, and we're not meeting like the California anti-renewal law provisions. There's such a heightened focus from both the plaintiffs' bar as well as regulators around these issues that, those are the types of things that can sink companies, especially if you're really early on and there's some indication that you're using data in a way that is not allowed. I mean, there's just so easy to attract that attention, and it could be so damaging to these companies. I mean, we're seeing settlements for small companies, approaching 10 million on data breach stuff. So, those are the types of things that, really could sink a company. Also, just reputationally. At the end of the day, if you're seen as somebody who is, capturing data, one, that data is worthless because it really can't be used in the way you want it to. And, the investors are onto that. They understand that data is oil, and the rights to that data is, the ability to pump it. So that's sort of where we're at.
Yeah, I mean, oftentimes when I talk to investors, they'll say, well, we don't really want to invest in a model that's not compliant. But we also want to we also want to kind of move the needle. Is there a happy place when you're talking to investors about what they should invest in, what they shouldn't invest in? Is there a baseline of compliancy that you would encourage them to look at from the privacy and security side?
Yeah, I mean, 100%. There's certainly going to be gray areas in consent. There's no one size fits all consent. I think we all kind of know that. But really, I think when you're looking at data use and that type of stuff, I think when you're in a situation where you can make defensible arguments that you can use that data versus just not having any sort of right to it, that's when the value of what you're doing is really destroyed. And I will tell you, in most of the diligences that we do, really for the last 3 to 4 years, have all focused on that data rights issues. It's a focus of the diligence. We're looking at the contracts. We're looking at how the company is using that data, whether or not there's any claim there, because with certain, I don't want to reveal too much information, but there's certain actors out there right now that are starting to make IP claims against companies, where if they're using data beyond what they were allowed to do, they're using that to develop new algorithms and new products. If they don't have that right, the companies who really are those data sources have the ability to assert ownership over algorithms and products that are created. If they fight that, sort of the jab before the hook is they're looking for algorithmic disgorgement and those types of remedies where they would destroy the product if you can't separate the data from the product that was developed. The FTC has done that a couple of times, and we're starting to see that in private litigation where if you were using data, there's an ownership angle, there's an algorithmic disgorgement angle, and there's a damages angle. So the companies that you are working with that are giving you that data are going to be pretty aggressive, as well as the regulators. So have a good basis, document it, and make sure it's defensible.
What about the withdrawal of consent? We have seen certain actions regarding surrounding genetics companies that will take your genetic data and then use it. And there's concerns about how that data might be potentially used. And there's been cases that have been brought where those users or patients would try to withdraw consent to using their data. Is there a process in place that an RPM company should have if for whatever reason their end user wants to eventually withdraw consent?
Yeah, and the individual has to be allowed to withdraw consent at any time. That's fundamental to any sort of informed consent, is you can stop there. Then it gets into various laws. So if you have a regulatory obligation to hold the information, generally both state laws as well as federal laws would say you can't destroy that. There are certain laws, like in California, obviously doesn't apply to HIPAA, but CCPA. There is a data destruction right that goes along with those state laws. So if you're doing more of a cash pay type RPM, where you might want to say, hey, we're not subject to HIPAA because we want broader data rights from using this information, along with those broader data rights that are based on consent, comes certain statutory obligations where an individual can ask you to destroy information, and you have to comply with that, and you have to document that. If you don't do that, then that's obviously both a private right of action in California as well as a potential government action. But so I think it's really important to understand what you need from a regulatory compliance perspective and have to keep, and what you can erase, like account information, other things that wouldn't be a part of either that designated record set or a requirement for a medical device to report adverse events or that type of stuff. So making sure you understand the data that you're keeping, understanding the regulatory obligations that you have to keep that data, understanding what laws you're subject to, and what an individual's right to demand that destruction may be.
Awesome. So Adam, I want to open this up to questions right now. Are you free to take a few questions if the audience has them?
Yeah, sure.
Awesome. All right. Do we have any questions for Adam Solander? Oh, one question came in is, what are the ethical considerations for informed consent in active listening devices?
I mean, anytime you are grabbing information, that individual has to be fully informed of the information that you're getting and your uses for that information. So if you're talking about the connected home type stuff, which we're starting to see more in care settings as well, where they're trying to identify it. Those use cases need to be out there. So I would actually say, because the active listening has, access to a lot more than, a monitor checking blood pressure, I think you would want to be way more granular on your informed consent, especially as it comes to the data use collection and, your privacy and security obligations. But yeah, I mean, I think there's a pretty high bar when you're talking about active listening and informed consent.
How can you use active listening to the benefit for your patient population? Going through the legal and regulatory checklist. So you know that there's benefit of having an active listening device with a lot of these connected tools, but you're unclear on how you achieve informed consent for someone that might have an Alexa or a Google Voice. How does
I think you have to be very clear about what you're listening to, what you're tracking, what you're keeping, what you're using that information for. I mean, it's just a matter of time before, I've fallen and I can't get up comes to the modern world. And we're starting to see that, like, especially in the elder care population, there's a number of companies out there that are engaging in active listening. They're engaging, in non-identifiable camera behavior, active listening, to try to identify when somebody may be at risk before, they know they're at risk, and alerting, that type of stuff. So I think it's just really important that the individual, before you're collecting this information, understands what you're collecting, how you're collecting it, and who you're sharing it with, and for what purposes. So it certainly has huge utility in providing care. And the question is whether or not you can draft a consent that's both understandable, that sort of releases you from legal liability.
Do we have any additional questions for Adam? It was a very detailed presentation.
Yeah, I have a question.
Thank you, Carol.
Sure. Well, going back to the OIG's report on, I don't know, their distress on seeing the family of RPM codes not being reported. Is there a way to rebut that, to explain just the facts that patient compliance was difficult, or it's not mandated that these codes be billed in a family? There's no the only add-on code is the 99458. It almost seems like they didn't quite understand what the code set.
Yeah, I think there is a lot of complaints about the RPM codes. I'm not a coding expert, but my colleague Igor, who couldn't be on today, I mean, that's essentially, if you send me that question, I can get you a detailed answer to it. But it's more than just that. I mean, I think the RPM codes were rushed in. I don't think they truly understood, how it would work. We hear complaints about it all the time, and I think those codes have hurt the adoption of RPM to a certain extent. And from what I do understand, not my area, but what I do understand is that there will be some fixes to those in the very near future.
I mean, I understand the code. I complain about them all the time, but just the fact that the OIG didn't understand how they were to be interpreted. I don't know. I guess somebody didn't teach the OIG how the codes worked. Like, there's things you do as a coder that you'll say, oh, I'm going to bill the 99457, which is a 20-minute code, even though I didn't get I didn't get the 16 days of data. I mean, that's allowed. So it's just kind of strange that they would pick on that, because that's an AMA thing. And, we've all fussed over how to build these codes for the last 6 years. And I'm not saying I'm sick of it, but I'm glad that the 2 to 15 days is going through. But
right.
I don't know. It just seems like the OIG picked on the wrong thing. Anyway.
Yeah. No, I definitely get your point, and not my area. I wish I had a better answer for you.
Well, if we don't have any other questions, I'd like to thank Adam for presenting today on an important topic and making it very understandable to someone like me who doesn't have a good grasp of some of these very intricate legal and regulatory issues like informed consent. So Adam, thank you again for your time today. And we are going to introduce our final panel.
That they would pick on that because that's an AMA thing. And, you know, we've all fussed over how to build these codes for the last 6 years. And I'm not saying I'm sick of it, but, you know, I'm glad that the 2 to 15 days is going through. But
Right.
I don't know. It just seems like the OIG picked on the wrong thing. Anyway.
Yeah.
Meh.
No, I definitely get your point, and not my area. I wish I had a better answer for you.
Well, if we don't have any other questions, I'd like to thank Adam for presenting today on an important topic and making it very understandable to someone like me who doesn't have a good grasp of some of these very intricate legal and regulatory issues like informed consent. So Adam, thank you again for your time today. And we are going to introduce our final panel, which is titled Safeguarding of Privacy and Security in RPM. We have 2 speakers with us, Honora Fernando. He's the Global Head of Medical Device Security at UL Solutions, and Anthony Magid, Dr. Anthony Magid, Associate Chief Medical Officer and Pediatric Physician at Rady Children's Hospital in San Diego. I'd love to, you guys are both on. I'd love you to say hello and introduce yourselves.
Hi, good afternoon, everyone.
Okay.
I'm Nora Fernando from UL, as most people know it, UL Solutions. And I've been with the organization for about 26-ish years. And also have been involved in other employment with the development of a large globally deployed digital health platform. So it's nice to maybe bring all those things together and have some conversations around this topic.
And nice to meet you, Anthony Magid. I'm a pediatric otolaryngologist, and including my clinical background and some research background is looking at access to telehealth for various communities to make sure there are no barriers to access based on socioeconomic status or payer. And then also part of my role at University of California, San Diego, is I've been the director of the Human Research Protections Program. So I have probably over a decade of experience of researchers using remote patient monitoring, subject monitoring, and to see how that interfaces and some of the really interesting challenges where you have remote patient monitoring that becomes the clinical care, but then people want to use it for both QI and for research purposes.
So we're going to have a conversation about privacy and security, and it's what everyone seems to care about now, given a climate of a lot of healthcare breaches and the releasing of protected health information. From a clinical standpoint and from a technological standpoint, what can we do to safeguard important PHI?
Like, you're going to go first?
After you, please.
Okay, so from a clinical perspective, I think it really is interesting. And again, all the talks have been fantastic, by the way. And the last one really, I think, led into this quite well, because when you look at regulatory oversight, HIPAA, for instance, and the very clear distinction about what is covered by HIPAA, which patients we think are more familiar with, but I think that oftentimes is opaque to them as well. But especially if you have a third-party vendor that has the data primarily that's not protected by HIPAA, and we talk about all the regulations that potentially would go into that type of data protection. But I think really understanding what then does flow into HIPAA, and apart from a clinician's perspective and a healthcare systems perspective, is for the individual to know what data is going to be part of their medical record. And I think that's the real key part, is how does that enter your system and what is actually going to be protected in your system? So making it HIPAA compliant, obviously. And then we really do lean upon the vendors who aren't covered by HIPAA to really understand what the level of security is for those individuals. And that's a huge concern that we have, is that people retain data. And I think that's fundamental to our organization, is that when you are working with a third-party vendor that potentially could maintain or retain the data, what we prefer is that is not the case, that we contract such that we actually own the data and that if it's going to be an agreement where that's going to be held on to by the third-party vendor, that has to be really, really assessed very carefully. And what is the reason for that? Is it to build a, AI database? Is it to be shared for other individuals? So really sort of maintaining control of the data, since we're the ones that essentially our patients are generating that data.
Excellent. I guess from my perspective, I'd like to kind of maybe even broaden the discussion a little bit, and perhaps going back a bit in history might be helpful to kind of build out some context for that broadening. If we look back to about 2 decades now, to the 2008 timeframe, we saw the American Recovery and Reinvestment Act introduce significant stimulus into healthcare. And part of the reason for that was to really drive innovation in healthcare. First transitioning from paper records to medical records, and then also looking at issues with other types of interoperability besides just that data. So, for example, being able to connect multiple devices to enable technologies like smart alarms, to reduce alarm fatigue in clinical settings and so forth. And so around the 2013 timeframe, we had the Federal Advisory Committee called FDASIA, which I had the privilege of serving on. Just to maintain the trend, it looks like several of the previous panelists knew Robert Jaron too. He and I sat on that together as well. But some of the things that came up there were that communication infrastructure at the time they thought was kind of like a piece of wire connecting two devices or two technologies. And subsequent to the rollout of that technology transition, we saw that maybe that's not quite the case, because when we look at communication infrastructure, we see a lot of different pieces coming together and a lot of emergent properties in systems, where systems in healthcare now have properties that aren't a function of any one of the individual devices. And that's kind of the case with smart alarms, for example, that are able to do things like reduce alarm fatigue. And so as we started to come to that realization, we saw that it's not just PII and PHI that needs to be considered, and that's absolutely important, especially from a HIPAA compliance perspective and so forth. But then when we get into these broader issues, it's also things like sensitive data. Those could be pieces of command and control information, for example. Monitoring information that may not be PII or PHI. It may be relatively innocuous looking from a HIPAA perspective, but it may actually have significant repercussions from a patient safety perspective, especially when aggregated and used with other data. And even if it's fully anonymized, if it's going into a machine learning environment, for example, with unsupervised learning, and that data starts to get skewed, we can start to see all kinds of potential unintended consequences, as someone alluded to earlier. And so, I think putting the whole system into a context beyond PII and PHI can be helpful to the conversation, especially as we get from remote patient monitoring to also remote control of medical devices.
So I often have conversations with vendor service providers or hospitals or health systems that say to us very proudly, I just talked to an RPM company that is HIPAA compliant. And what we often say is you can't be HIPAA compliant. There's like no checkbox to be HIPAA compliant. You could follow HIPAA guardrails and regulations, but no, HIPAA doesn't certify a product or a platform to be compliant. So I would love to dive into the question of what checklist items does a hospital or health system or anybody that is purchasing these RPM devices, what type of checklist do they need to have as they are figuring out as they're weighing and looking at vendor selection, and they're trying to focus on privacy and security.
I can start from the non-technical standpoint. So that's probably in terms of where the data is housed. I mean, again, not my expertise, but where the data is housed, what are the securities, who has access to that data. And that's a very important, not only from a technical standpoint, but also from a policy standpoint, who has access. And then when the data is being transmitted, is it in an encrypted fashion? And then preferably, we like to actually disassociate any identifiers from the data itself, if possible, and then reattach them. So if there were to be a breach, that there would at least be some difficulty in matching up the data with the actual individual. And I want to point out one thing, and I really appreciate the concept of sort of broadening the data that we capture, is there's a fair amount of data we capture that's visual, that especially for remote monitoring, seizure disorders, even behavior in the home, eating disorders, there's a big move afoot. You actually observe people in their home. So even to broaden it even more is oftentimes they're not even looking towards the patient to provide consent, but to appreciate the environment that the data is being captured. And is it an environment where there's an assumption of privacy? And who else could be in that environment that we have to be aware of?
So I kind of come from a world that a lot of people think of as the world of checklists. And that's where standards can really come into play quite a bit. There are some tools. So people like to develop checklists because you can almost mindlessly implement them. You go down the list and you check the box. While that has its place and value, it may not be the optimal way to go, especially as system integration, even at the individual product level, things become more complex. And so there are a lot of tools that have been developed. For example, MITA, the Medical Imaging Technology Association, part of NEMA, developed what's called the Manufacturer's Disclosure Statement for Medical Device Security, or the MDS2. So that's a really nice tool that's been adopted around the world, and it looks at security issues and the disclosure of those security issues. And it's not only a standard, but it's also an Excel checklist. And so there are some tools like that that are helping progress things. There are also standards. For example, you all back in the 2015, 2016 timeframe, we issued or published a standard called the UL 2900 series of standards. And what those did was they functioned under the Cybersecurity National Action Plan that was deployed at that time to support what the White House put forward as a cybersecurity assurance program that was supposed to support the Cybersecurity National Action Plan. And so in standards like that, we have a number of different pieces. We have things like security controls that are recommended. And so you can look at the lists of security controls and those requirements and see if the ones that are called out in the standard are relevant to your deployment and things like that. And then you can, on top of that, you can even do some testing to prove that checklist item has been satisfied. So now you've got not only the checkbox, but you've got some objective evidence saying, okay, that checkbox has been properly dealt with, and here's my proof that I actually comply with it. But an integral part of a lot of medical device standards and a lot of healthcare technology standards is risk management. And the reason for that is because the risk profiles vary so widely from medical device to medical device. You could have something like a tongue depressor versus something like an MRI machine. And the risk profiles are very different, across that entire continuum. And so risk management and as a process becomes a very important and integral part of driving risk management decisions, especially in procurement and so forth. So let's say as an HDO procurer, you want to think about the use cases of that technology. And you also want to think about those use cases in the environment, in the network architecture that you're going to deploy it in, and so forth. And so, this notion of checklists, I think, is a good starting point. But I think we need to evolve beyond that to understand threat models of the whole system and where vulnerabilities exist and where security technologies need to complement healthcare delivery technologies, and really build a more robust picture of the overall healthcare ecosystem that's being supported.
You bring up a unique point, is that RPM is not only collecting data on that individual user, it's actually more personal than that. It's going into that, potentially into that user's home, specifically for those that are dealing with substance use disorder and those that are dealing with disordered eating. How do you safeguard against how do you protect data that might not necessarily be specific to that patient? Does the privacy attach to wherever the patient is, and if I'm sitting in my home, the privacy attaches to my home, or does it just attach to me? And if I have a family member that's close to me and says something, I mean, how does that work in terms of both the technical piece and the clinical piece?
From the clinical piece, we actually have to spend quite a bit of time with the subject or the patient to understand what their environment is, to make them aware that they have the opportunity to turn off the monitoring system at any time. And we even so much as to say that in certain environments, we actually put up signage in the home. If it's remote monitoring, because there are times you talked about, I've fallen and I can't get up, that type of thing, that if you actually have cameras in the home, which sometimes you'll do, for looking at people either live alone, you're trying to monitor some type of, signal, like a seizure is a good example. Even what people eat, especially for research purposes, you may actually have a body camera on, that we actually will put signage in the home to make other people aware that a recording is in place. And the other is to selective the type of data that you're acquiring, whether it's infrared, whether the images themselves are actually identifiable sitting alone, or whether there are times that they would have enough detail and they're pixelated enough that you could actually on their own identify who the person is. Same goes with GPS. That's something we come up with all the time, both clinically and from a research standpoint, is that if you have a device that has GPS associated with it, especially if it's an activity monitor, that has to be very clear in terms of what data is being captured and how that can be shared.
And, from kind of the technology engineering side of it, that becomes a pretty significant challenge, when the technology vendor doesn't have the ability to influence, how things are handled in that end use environment, like the signage the doctor just mentioned. And so we, from a device or technology perspective, we have to think about reasonably foreseeable misuse and things like pseudonymization and anonymization of data in general, and also the full life cycle of that data, so that even if data is acquired, and logs and things like that, as the device is disposed of, that data isn't exposed in either aftermarket environments or even, people like dumpster divers, for example. So there are needs for a kind of a strong handoff up the supply chain from the technology vendor to the end user. So a lot of that still needs to be refined, I think, from the perspective of service level agreements, specificity of contracting and so forth. And there are some organizations like the Healthcare Sector Coordinating Council and so forth that kind of help drive things with, model contract language and those kinds of things as well.
So we've probably all read the same news reports where there are in-home monitoring devices that have been hacked that are used for security purposes. And some of these devices operate very similarly to how these RPM technologies operate and being able to monitor the patient. What extra safeguards does an RPM device that's using video or audio monitoring technology have to go through compared to that of, let's say, a security camera?
We'll lean on a human interface. And I think that is something that you talk about anonymizing the data that is, and liability is a huge issue as well, is that it really does, this is discussed earlier today, that it really does fall on the clinician in terms of responsibility, that if there's going to be a breach or if data is going to be used inappropriately, because oftentimes it's the clinician who sort of drove getting that device involved. So having a human interface and as quickly as possible, potentially getting rid of the raw data, but translating into a form that is more easily controlled, so to speak. And having that sort of human filter, as it were, as faulty as we are right now, that if you can take responsibility for what's being done, to at least at this point in time, I'm sure it's going to change very quickly, is to be somewhat of the gatekeeper.
And some of the kinds of things we see from a technology deployment perspective is the opportunity for data leaks, that are sometimes not readily foreseen. And this is where, once again, that binding between kind of the clinical user and the end user and the technology vendor becomes really important, because a lot of times we'll see a technology like TLS, and maybe not everybody here is familiar with TLS, but if you look at your website, they tell you to look for HTTPS instead of HTTP to know that it's secure, and the little lock symbol. Well, what TLS is from an implementation perspective is it's a point-to-point protocol. And so if you have data that's integrated across a large system, so let's say you have an IoT endpoint device in somebody's house, like a camera, for example, that's acquiring data and then sending it to some kind of service that's cloud-based, maybe, and does data aggregation, and maybe can route it to a clinician or those kinds of things. Well, that can be one of many possible hops or integration points in that chain. And so if you encrypt end to end and you control those keys carefully, that can help you avoid situations like having key disclosure outside of HIPAA constructs like business associates agreements and those kinds of things. And that can help protect the data. So, that coupled with authentication and authorization processes and so forth, from a technical perspective, can kind of help lock down that data in better ways than it might be with more innocuous consumer IoT technologies and so forth.
I remember giving a presentation to an audience that was really, it was a caregiver audience, very concerned about engaging and implementing technology as a way to help care for these at-home patient populations. And I asked the question, what is the biggest impediment to adoption by the patient? And one of the patient concerns usually all come back to this issue of concern breach or risk that the device might be tampered with and someone might have essentially access to an elder person's home inside their home, or access to geo-tracking of their location. And this is already like a sensitive patient population that is already targeted in so many different ways. And I just thought that was so interesting is that a lot of those that were polled said, yeah, we would love this device. I mean, we're fearful of falling. We're fearful of, our kids live hundreds of miles away. We're by ourselves, but I'm also concerned about bringing in a potential hacker to my living room that could watch and track me. So you're saying that that's probably, while it's happened on some of these at-home monitoring devices, it's probably a little different for these RPM solutions because they have a higher level of safety checks.
And
yeah,
Yeah, and I think that's where you have to look at the purpose of the RPM. If it's something to alert someone to a fall, obviously it needs to be in real time, and you have to have the connectivity. If you're looking for tracking behavior over time where you're not going to act upon it, it's basically collecting data remotely. There still is the potential of having a device which is essentially offline that can, physically be controlled, but then you lose all the tremendous value of responding in real time. So I think this is, we use all the minimal necessary data is something we talk about quite a bit. And this is something I think you can sort of really look at what is the purpose of the RPM and does it need to be real time, where I think you have to enlist all those technological protections. And if it really is something where it's just as nice to have, cumulatively after several weeks, that you actually potentially could be offline while you're collecting that data.
Yeah. And being able to monitor and sometimes predict people's behavior, and it's a double-edged sword. Like even if you look at utility meters, for example, for your electricity usage, it's been well over a decade now that threat actors have been able to hack into those wireless connections, look at things like power utilization and tell whether or not people are at home during certain hours and things like that, making them more attractive targets when nobody's home. So, there are just so many different angles to this, and the data can be used in so many different ways, both positively and nefariously.
We have about 5 minutes left of this session, and I want to see if our audience has any questions. Audience, the panel is now open, and you could ask questions to Dr. Magid or Nora Fernando. Okay. Let's see, we have one in the chat. Oh, Carol just says it's very interesting, but she doesn't have any questions. So we must have done a really good job in asking all the questions. Right. Well, we don't have any other questions, but do you have anything else that you'd like to leave our audience in the last 3 minutes of this session?
I'll just say, very briefly that patients who are cared for using RPM, I think just really educating that this is additional information that will become part of their medical record, and that for them to appreciate that sort of what is being captured, because people, as you said, people are very protective of what's going on in their home. People also are very protective of what's in their medical record. And I think it's important for them to understand what's going to be in the record and what would essentially be disposed of and not filtered.
Absolutely. And I guess from my side, I would say, recognizing that security is a shared responsibility and taking self-accountability sometimes can be really important, because all of the rules aren't in place yet to drive it across the ecosystem.
And just from a compliance standpoint, there is both a state and federal split here. The federal law sets the standard for where the bar needs to be, but states can be more restrictive. So if you are a healthcare provider, or if you are a vendor service provider, you need to be very mindful of what those 50 states say, because many states are actually more restrictive than where the federal law sets the bar. So, and if you're interested in that research, CTeL has it, and you can find it in our digital library. Go ahead, Dr. Magid.
Yeah, I say California. I live in California, and California has a pretty high bar now.
They do. I believe they also have reclassified what is considered a sensitive patient. And so that used to be defined narrowly for patients that were in the SUD space, but now it's actually expanded to persons who are unhoused and a couple other categories, which carries with it more legal risk. So if for that patient, if that information is somehow breached or shared inappropriately, there's more penalty that goes along with it. All right. Well, we are so grateful to the both of you to have such experts here to talk with us today. I wanted to thank you. I encourage any of you to please engage formally with CTeL or join our AI Blue Ribbon Collaborative. We've really had a great time at the RPM Summit. Our next meeting will be in December 9th and 10th in Washington, D.C. at the U.S. Capitol. So if you are interested, please join us at the U.S. Capitol, and then again in March for our inaugural AI Summit, presenting to members of the House and Senate. So thank you, everyone. What a great RPM Summit. And if you need anything else, you know how to reach us, info@ctel.org. Take care and bye for now.